Arul Chawla to start the session, as Dr. Gagan will be coming a little late. And Tanu will co-chair the session, so kindly start the program.
I congratulate Dr. Suresh and Dr. Parul for initiating this program, this wonderful program. So we'll be starting with the first talk, Understanding the Basics of A-Scan Biometry by Dr. Ujjwal.
To Dr. Suresh sir and Dr. Parul ma'am for giving me the opportunity to present at this PG teaching program. And I'll be talking about the basics of A-Scan biometry. To begin with a little bit of historical perspective, so in 1949 when Harold Ridley implanted the first IOL, he had a refractive surprise of nearly 20 diopters. In 1970s, more accurate A-scans were available and several studies were done to establish theoretical Vergennes formulas. Till date, these formulas have been subjected to minor and major alterations in variables. The axial length can be defined as the distance from the anterior corneal surface to the retinal pigment epithelium, and it is measured using optical or ultrasound methods, which can be further of direct contact or immersion methods. It is the most important parameter in modern day formula because any change in the IOL power by nearly 2.5 to 3 times can be derived due to any error in the measuring of axial length, and this is more so in short and long eyes. The most commonly talked about formula is the SRK, and by that I mean Sanders, Retzlaff and Kraft, who gave us the formula P power of the lens is equal to A constant minus 2.5 times the axial length minus 0.9 times the mean keratometry. It has now been replaced with newer generation formulas, but it's still useful for understanding the relationship of the variables. So how do we measure the axial length? So we have different methods available. The first is the ultrasonography method or the contact method. Under this we have the applanation method. We can see the image over here. It's much like a Goldman applanation tonometry, but it's not very commonly used. Then we have the contact method, which is the handheld method with a probe, and then we have the immersion A-scan method. Under the optical methods, we have the Zeiss Humphreys IOL Master and the Lenstar by Hartstein. So these are non-contact methods. So what is the principle of A-scan? So it uses mechanical waves to calculate time needed for a pulse to travel from the cornea to retina. Now sound travels with different speeds as per the media. And the interface is the junction between any two media of different densities and velocities. So the spikes that we get in the A-scan are because of the interface of the anterior corneal surface, the aqueous anterior lens surface, which produces the second spike, the posterior lens capsule and the anterior vitreous interface, which produces the third one. The posterior vitreous and the retinal spike is because of this interface, and lastly the choroid anterior scleral surface interface produces the fifth spike. This is followed by a retroorbital short spikes due to the orbital fat. So in A-scan, the parallel sound beam is emitted from the probe tip with an echo bouncing back into the probe as the sound beam strikes different interfaces. This is then converted, the distance is derived by the time and the velocity. So A-scan is a one-dimensional display in which egos are represented as vertical spikes from a baseline. In ophthalmology, most A-scan and B-scan probes use approximately 10 billion hertz, which is pre-designed by the manufacturer. So how do we do? This is the procedure for the contact method. Always explain the procedure to the patient before you start the procedure. We can numb the eyes using topical anesthesia like Paracaine. We have to clean the probe always before we use the A-scan probe. It is placed on the patient's cornea as shown in the diagram, in the image, and the operator must aim the probe towards the macula of the eye. This is important because if the probe is aimed towards the optic disc, then we will not get the retroorbital spikes, and that means it's an erroneous reading which needs to be discarded. So the alignment with the optical axis will be indicated by high lens spikes, then high retina spikes followed by scleral and descending orbital fat spikes. So this is another image showing the contact method at our hospital. It is the handheld method. So how do we interpret the contact method or A-scan graph? So the data can be entered into the system. We can enter the keratometry values over here, K1 and K2. As you can see here, the first spike is because of the cornea. The second one is because of the anterior lens surface. The third one is because of the posterior lens capsule. Then we have a flat vitreous face, and then the retina shows a spike which is very sharp, followed by a scleral and then retroorbital spikes. Besides this, we also get data of anterior chamber depth, the lens thickness, and also the vitreous cavity length from the A scan. The actual length can be displayed here. The IL power can then be calculated by the different options available. The gain can also be increased according to the media or the density of the cataract. So the ideal A scan, it measures, so if you're perpendicular, your graph will show equal double corneal peaks. There will be 5 high sharply rising echos. There will be descending orbital fat behind the scleral echo, and it will be a reproducible reading. So if you take multiple readings, they have to be approximately the same. There are different modes in A scan that are available. So you have the normal mode, then you have the dense mode, for which you can use for dense mature cataracts. There's the aphakic mode, which you can use for secondary IOL implantation. Then you have the pseudophakic mode, which also has further options according to the type of lens that is implanted, PMMA, silicon and acrylic mode. This can be used for the IOL exchange surgeries that you are planning. And then lastly, we also have the silicon oil fill method. So the contact method has disadvantages. As the probe touches the cornea, it can result in corneal compression and resulting in a shorter axial length. So this can be solved by the immersion A scan method, which is more accurate as it eliminates the corneal compression and is shown to be superior to the contact biometry. It is now accepted as a gold standard in most institutes. So this is what the immersion A scan looks like. It has this Prager shell or the immersions shell here. Now the probe is inserted inside the shell over here. There is a mark over here. It is important to keep the mark and the probe at the same level, because if this advances, the reading will be erroneous. Once it is at this level, it can be tightened with a knob over here, which can fix the probe. Now this is a short video showing the procedure. The patient is made to lie supine. The cornea is anesthetized with Paracaine. Then the fluid is injected and a water bath is created. And once that is done, the readings are taken. So how does the immersion A scan graph look like? It is slightly different from the contact method in that the first spike here would be because of the probe and the aqueous water bath. The rest of the graph is same as the contact method. Now I'll just describe a few scenarios of A scan. This is a mature cataract. So here generally what we have to keep in mind, if the spikes are not of good quality, we can increase the gain and then we can use this also in the dense mode. A scan in pseudophakia, this will show this single spike because of the lens. This is a 4-year-old child who was planned for secondary IOL. So in this you can see here there is no lens spike in the vitreous cavity. All the readings and anterior chamber depth are all 0 here. And in such cases it is better to cross-check the axial length by another method. So here we use the B scan to cross-check the axial length, and it was pretty much similar to the axial length by the contact method. This is another scenario of the A scan in a retinal detachment case. Here you can see 2 spikes in the mid-vitreous. So this is what it will look like in a case of retinal detachment. This was another case of cataract. We were doing workup and we found that there was a spike in the mid-vitreous cavity, and when we did a B scan, it was confirmed to be a PVD. Now A scan in silicon filled eyes can be tricky because the true axial length is often unknown and the measured axial length is greater than the true axial length. So in such cases, we can multiply the measured axial length by a conversion factor of 0.71. So this is how we can derive the true axial length in a silicon oil filled eye by the contact method. But studies have been done to compare the IOL master and the A scan biometry in silicon oil filled eyes, and they have found that the IOL master overall has more accuracy and less deviation in predicting the post-operative refractive errors. So if you have the option of IOL master, it's preferred to take that. There are other applications of A scan as well. It's used in pediatric cataract surgery, in keratoprosthesis surgery. If an aphakic K-pro is being planned, the axial length of the eye is measured by an A scan. Coming to the optical methods, we have the IOL Master and the Lenstar. At our institute, we use the Lenstar method. The principle is partial coherence interferometry, and it uses light rather than sound to measure the axial length, the corneal radius, and the anterior chamber depth of the eye. So this is the image of the Lenstar. The patient is made to rest their chin on the chin rest, and the rest of the readings can be taken. The patient must be cooperative enough to fixate well, and we can take the readings, and from this graph we can choose the different types of IOL powers and also the type of lenses. So the IOL Master, however, has its own limitations in dense cataracts, in hazy medias, and in patients who are unable to fixate. It does not give very accurate readings, or sometimes it does not give a reading at all. So whenever in doubt, we can use a combination of techniques. B-scan can be used to confirm the axial length if you have a questionable A-scan, which can improve the accuracy. The IOL Master is superior in cases of posterior staphyloma and in cases of silicon-filled eyes. So to summarize, for immature cataracts, we can use all these options, but immersion A-scan and optical biometry can be preferred. For mature dense cataracts, immersion A-scan would be the method of choice. Silicon-filled eyes and posterior staphylomas, optical biometry would be the better option. And in pediatric cataracts or in doubtful cases, it's always better to use a combination to confirm the axial length. So the take-home message would be contact ultrasound measurements have been the gold standard, but can have subjective errors due to corneal compression. Immersion measurements, they avoid corneal compression but have less control over alignment, so they can give varied results. The optical methods have benefits of non-contact procedures along with greater accuracy, but sometimes in dense cataracts they can give us false readings, or they are not possible. So overall, combination of techniques can be used. Thank you.
But we will know that we are actually calculating the refractive axial length rather than the anatomical axial length, which we tend to calculate in cases of posterior staphyloma. So IOL Master 700 is very good in that way. Then verify what you're doing is correct or not.
I'd like to thank Dr. Parul and Dr. Suresh for giving me this opportunity. So let's just start with the basics of keratometry. So the learning points here would be a brief history, the principle, the various types of keratometers that are available, the procedures and the applications. So cornea, as you know, contributes to around 2/3 of the total refractive power of the eye. And if we look at the shape of the cornea, it is a prolate ellipsoid which is steeper in the center and tends to flatten towards the periphery. And it is actually this corneal curvature that imparts this refractive power to the cornea. And keratometry is nothing but measurement of this corneal curvature. Keratometry is also termed as ophthalmometry. So by definition, keratometry measures the radius of curvature of the anterior surface of the cornea. So if we can just go through a brief history, it was in the 17th century that Scheiner gave the first idea of measuring the anterior curvatural radius of the eye. However, the working keratometer was first given by Helmholtz and Jawala and Scholz in the 19th century, while the automated keratometer came up only in the 1980s. Now, while understanding the basic principle that's involved in the keratometry, it is important to understand that the cornea basically behaves like a spherical reflecting surface. You can imagine a cornea to behave like a spherical convex mirror. So when an object of a known size kept at a known distance is shown in front of the cornea, the image is going to get formed onto the cornea, and when we can measure this image size, we can reduce the radius of curvature of the cornea with this formula. One of the important aspect while measuring this image was the difficulty that because of the micro movements of the eye, it was difficult to actually measure the size of the image. And then came the concept of image doubling. The concept of image doubling was introduced in the keratometers, where we were imparting a prism in the keratometer and that would double the image. So what would happen that with every movement both the images would move together, and then it became easy to actually evaluate and estimate the actual size of the image. Now, as you know, the keratometry reading can be taken in two according to two types. First would be in millimeters, that would basically tell you the radius of curvature of the anterior surface. However, when we talk about the corneal power, we are basically talking about the dioptric power of the cornea, which is measured in the keratometers or is termed as K readings. And this relationship can be understood with this particular formula, where the dioptric power is equal to N, that is the aggregate refractive index of the cornea, taken as 1.3375 minus 1 divided by your divided by the radius of curvature that you've obtained in millimeters. And this helps us to convert the millimeter readings into the dioptric power. Now coming on to various types of keratometers. So when we try to manually evaluate or estimate the size of the image, we are using the manual method of keratometer, while when we use an automated device where the image is calculated by the photosensitive device that is basically present in the system, and that system would only calculate the image size, that would be termed as automated type of keratometers. So keratometers that are generally available in the market would be an auto keratometer, and they tend to generally come with auto refractometer along with it. So they are then called as auto keratorefractometer. But when we are trying to take when we are calculating the IOL power of the eye, we tend to go towards the optical biometers, which have an inherent autokeratometer adjusted to them. And the various biometers that help us to know the keratometry readings are our IOL master and Lenstar. While keratometry readings can also be obtained from various topographic and tomographic methods like your pentacam and your OpsCam. Now when we look at the manual keratometers, two important manual keratometers that have remained gold standard for the longest period of time are our Bausch & Lomb type of keratometer and our Jawal-Schwartz type of keratometer. So Bausch & Lomb basically is a one position keratometer where we don't have to change the direction of the keratometer to measure the second reading. While the two position keratometer, which is basically your Jawal-Schwartz type of keratometer, here the entire keratometer has to be rotated by 90 degrees to measure the second meridian, and hence termed as two position keratometer. Just a brief stepwise technique that we need to know while we are calculating the keratometry readings. So the first step would be to fixate the eyepiece or to focus the eyepiece. So the first step would be to get over this doubling that you can see in image A. Okay, and that can be done by rotating the eyepiece knob till this doubling is taken care of and there is centration of this plus sign or the crosshair that you see. Okay, this is the position where the optical axis of the instrument has now been aligned with the visual axis of the eye. Then we have to know the axis of the eye, and that can be done by rotating the axis knob and where the plus signs come to lie just in opposition to each other. Then comes the second reading, then comes the next step where we are measuring the horizontal meridian. For that we have to rotate the horizontal knob till the plus signs get superimposed on each other and we get a single plus sign. And then we go and rotate a vertical meridian knob where now there is superimposition of the minus sign and we tend to get this minus reading. And at this position, whatever the reading has come, that has to be noted along with their axis, and that would give you your keratometry reading, which is basically denoted as K1 and K2 reading. And by convention, K1 would mean the keratometry reading along the flatter meridian and K2 would mean the keratometry reading along the steeper meridian. The difference between the keratometry reading would give you your astigmatism. It would be imperative to know that you should take at least an average of 3 readings along with your axes to come to a final keratometry reading while you are doing your manual keratometry. The limitations would be manual keratometers tend to give you accurate results till there is regular astigmatism. However, keratometry readings are quite erroneous when it comes to irregular corneas. Also, 2 different types of keratometers will not give you exact same reading, so that also has to be kept in mind. Just a brief concept of extended keratometry. So what happens is that your manual keratometers has a specified range of 36 diopters to 52 diopters. However, we can increase this range by introducing some spherical lenses. So for steeper corneas, we can introduce a spherical lens of plus 1.25 diopters and thereby increasing the range to 61 diopters, while for flatter corneas, we can introduce a minus 1 diopter spherical lens, and that would extend our range from 36 to 30 diopters. So the final range would become from 30 to 61 diopters. However, for all practical purposes, since most of the places have now optical biometers, the keratometry readings that can be taken with optical biometers can be in the form of 6 reference points, as we can see in IOL Master, where the keratometry readings are taken through 6 reference points in an optical zone of 2.3 millimeter. And here we get 3 keratometry readings, and if there is presence of any cross mark in front of any of the keratometry readings, we need to repeat the reading. It just indicates that probably the fixation was not good while we were taking the keratometry readings. While in the lens star, we have basically 32 reference points which are oriented in 2 circles, the outer having an optical zone of 2.3 millimeter and the inner one having an optical zone of 1.65 millimeter. And the readings come out something like this, where we get the K1 reading, K2 reading, and the difference would give you the astigmatism. And here, as you can see, the keratometric index or the refractive index that we've already seen has been taken as the standard, that is 1.3375. The advantage of the optical biometers would be that it is a quicker process, it has a shorter learning curve, it has good inter-examiner repeatability, and certainly it gives you added information in the form of axial length, anterior chamber depth, white to white diameter, and things like that. However, you can get erroneous reading if there is presence of any opacity that is lying within the optical axis, or if the patient is not cooperating for proper fixation. So the sources of error while measuring while taking any keratometry readings would be poor patient positioning or fixation, or it can be examiner related, where the examiner himself has a reduced visual acuity or has uncorrected refractive error or has accommodative fluctuation. That would again lead to improper focusing of the Mayas and hence improper reading. Also, presence of ocular surface abnormalities in the form of dry eye, meibomian gland disease, and corneal diseases like dystrophies and opacities would also lead to erroneous readings. So where do we use keratometry? So as we have seen, keratometry tends to help us to tell us about corneal astigmatism, that is regular and irregular astigmatism. It very well is important to calculate our intraocular lens power. It is also helpful to estimate the base curve while we are doing contact lens fitting, and it also helps to manage the pre and post surgical astigmatism. So as you can see in this example, I'm so sorry. As you can see in this example, the difference between the keratometry reading would give you the astigmatism. So in the first example, you see that the steeper meridian is lying along the 90-degree axis. So here, the type of astigmatism would be with the rule type of astigmatism. While in the second example, you see the steeper meridian is along the 180-degree axis. And that would mean that the type of astigmatism is, so basically your horizontal meridian is steeper as compared to the vertical meridian, and that would make it an against the rule type of astigmatism. As it was already highlighted by Dr. Ujjwal, that how important it is to get an accurate axial length measurement along with that keratometry reading while we are calculating the intraocular lens power. So while calculating the intraocular lens power, we are not just observant about the K1 and K2 reading, but what we take is an average of your keratometry reading. And if you can just go through this formula, you can see that the keratometry reading has to be so accurate that even a 1 dioptric change in the keratometry reading would lead to a post surgical refractive surprise of the same amount, that is around 1 diopter. So the keratometry reading should be very accurate while we are planning an intraocular lens power. Secondly, it would also help us to decide the site of incision while doing cataract surgery. So if the incision is taken along the 5 to 1 diopter. And how do we decide that? So this would help us to decide whether to take a superior or a temporal incision depending upon the type of astigmatism that the patient is having. So here the patient in the right eye has a steeper axis along the 85 degrees. So that would mean the vertical axis is steeper, so here we would prefer taking a superior incision. While in the left eye you see the steeper axis is along 172 degrees of axis, and that would mean the horizontal axis is steeper, and here we would prefer doing a temporal incision for cataract surgery. Also, keratometry reading help us to decide the position and the length of the relaxing incisions that can be taken at the limbus, which helps to relax or flatten the steeper axis, and at the same time it steepens the opposite or the flatter axis against that, and that would be the basis of the coupling effect that we take into account while doing the limbal relaxing incisions. So either a single incision can be taken along the steeper axis. In order to increase the amount of correction, we can do a coupled or two incisions along the same steeper axis, and this tends to correct about 1.5 to 3 diopter of astigmatism, can be done along with your cataract surgery. Just a brief note that in cases of dense corneal opacity where keratometry reading might be very erroneous, in that case what we can do is that we can take the keratometry reading of the other unaffected eye, or we can take a standard keratometry reading of plus 44 diopter in order to calculate our intraocular lens power, especially done for our triple procedures that we do for our triple procedure, that is penetrating keratoplasty with cataract surgery. Before I just end the topic, just a brief mention of something known as conventional or standard keratometry and total keratometry. So as you would have seen, at all points in time, we were telling that keratometry is measurement of the anterior corneal curvature, right? But cornea basically has anterior and posterior surface, and both of them have a different curvatural dimensions. So a conventional or standard keratometry would just take into account only your anterior corneal surface, but total keratometry takes into account both the anterior and the posterior corneal curvature, and an aggregate of that would give you your total keratometry. So total keratometry can be measured using your Scheimpflug based imaging, where we take into account both anterior posterior surface, and also the LensStar the IOL Master 700, which is based on swept source OCT. That also takes into account both the anterior and posterior surfaces of keratometry. And what they say is that the conventional keratometry tends to overestimate the keratometry readings by around 0.5 to 1 diopter. So this is the latest that is coming in, and this would be the difference between the conventional and the total keratometry. Yeah. Thank you.
Formulas
of the IOL calculating formula. So what we need to remember is that earlier the cataract surgery was primarily performed to remove your cataractus lens. But right now in the present scenario, since our biometry has become so accurate, the of the patient should be 6 by 6. So as we have already discussed in the previous two presentations about the biometry, which includes your axial length and your keratometry, and since currently we are using the optical biometry, that is quite accurate. So these two preoperative variables, they provide a very accurate reading. We will be discussing about the various formulas about how to calculate the IOL power and the clinical variables that affect the IOL power. Now another concept is of the effective lens position. Now what do we mean by this is that it determines the final IOL position after the cataract surgery is done. So this is one of the variable which post-operatively is going to define your refractive outcome. So this is one of the variable which we are now working on, and all the newer generation formulas is taking into account about this factor, so that the refractive outcome of the patient is accurate. So just a brief overview about what has been already discussed. The biometry basically includes your axial length and your keratometry. In the axial length, it can be done using the ultrasound A-scan mode, which can be either done through the applanation or the immersion method, and then there is optical biometry. Similarly, for the keratometry, you have the manual, automated, and the optical one. And we all know that right now we are doing the optical biometry because that provides you the most accurate result. So what we need to know in the axial length is that the difference in the two eyes, in between the axial length of the two eyes should not be more than 1 millimeter. If the difference is more than 1 millimeter, that means there should be an underlying pathology which should be present in the eye. So if you are not suspecting any pathology in the eye, you should always repeat your axial length in such cases, because otherwise you will have an erroneous IOL power calculation. Also, the normal axial length range, which we say is between 22 to 24.5 millimeter, is the range in which all the IOL powers are going to provide you roughly the same result. So it doesn't matter if the axial length is in this normal range. However, if your range of the axial length is less than 22 millimeter or more than 24.5 millimeter, it is at that point that you need to be you need to think about that which IOL power you have to use. Similarly, for the keratometry, the difference in between the two eyes should not be more than 1 diopter, and the difference in between the K1 and K2 of each eye, of one eye, should not be more than 1 diopter. If it is more than 1 to 1.5 diopter, that means an astigmatism is present. So a simple spherical correction of the IOL is not going to provide a 6/6 vision to the patient post-operatively, and hence in such cases you will have to decide about the toric IOL. The range of the keratometry, generally the normal range ranges between 40 to 47 diopter. Now why is this important that you should see the range? Is because if it is less than 40 diopters or more than 47 diopters, that means there is some pathology which is present in the cornea. See, for example, if it is more than 47 diopters, that means you are suspecting a corneal ectasia. So if you operate the patient at that point, if the keratometry is more than 47 diopters, post-operatively the patient might have a vision of 6/6. But you will see that after 3 to 6 months, the patient will again come back to you with a complaint of diminution of vision, which can be due to the progression of the disease, the corneal ectasia, if it is present. So it is important that you see your keratometry and your axial length values previously only, so that you can counsel your patient accordingly. Now in this, you just need to know that we have various generations of the formula that have been described. What is important is that as the generation of the formula increases, with the higher generations, these are newer formulas which have more number of variables in them, so they tend to be more accurate. Classically, we have defined the IOL formulas as the regression or the theoretical formula. A regression formula is derived from retrospective computer analysis of post-operative result of large number of patients who have undergone surgery, whereas a theoretical formula is derived from the geometric optics as applied to the schematic eye using the theoretical constants. So this data-driven or the regression formula includes your simple regression and your artificial intelligence formula. Then you have the optical based formulas, and then you have the hybrid formulas, which is a combination of both the data-driven and the optical approach. What is important in this case is that the simple regression formulas were the ones which were earlier used. These are not now commonly used. What we are now using is the more advanced and the newer generation formulas. The first IOL formula that was described was the SRK formula, as has been discussed previously also by Sanders, Retzlaff and Croft. They basically have provided an equation for calculating the IOL power, which states A minus, wherein the A is your IOL constant that will depend upon the IOL and the manufacturing company of the IOL, minus 2.5 into the axial length, which is in millimeters, minus 0.9 into K, which is the corneal power or the keratometry, that is in diopters. Now this SRK formula and other first generation formulas, they work very well for the average axial length, which is your 22 to 24.5 millimeter range, but inaccuracies is going to occur at the extremes of the axial length, which means that generally in longer eyes, a stronger IOL power is calculated, so post-operatively the patient will have myopia, whereas in shorter eyes, a weaker IOL power is calculated, which means that post-operatively the patient will have hyperopia. So certain modifications were done in this SRK formula, which is the SRK2 and the modified SRK2, wherein the basic concept that was applied is the same, that if the axial length is shorter, that is less than 22 millimeters, since post-operatively a weaker IOL power is calculated, that is why you need to add more power to the lens. And if the axial length is more than 24.5, since a stronger IOL power is calculated, so you need to subtract the power from that final calculation. Now, depending upon the various generations of the formula, as we keep on progressing towards the newer formulas, more number of variables are included in calculating the IOL power. For example, in the basic formula, you will see that the axial length and the keratometry is included, whereas as we keep on progressing, the other variables including your anterior chamber depth, the wide to wide diameter and the lens thickness is also included to make it more accurate. We'll just move into one of the case scenario as to how to calculate the correct IOL power. This was a 40-year-old male patient who presented with gradual diminution of vision in both the eyes. The vision in the right eye was 6/18 and left eye was 6/60. The cataract was present in both the eyes but was more in the left eye. So we did the axial length and the keratometry both using the optical and the manual method. What is more important to know in this case is that we take the optical power of the optical variable that is calculated since it is more accurate. Also in this example, you need to see that the axial length is quite high, quite beyond your normal range, which is 30.11 in the right eye and 30.2 in the left eye. So your normal IOL SRK formula is not going to give you accurate result in this case. For example, using the optical biometer in the left eye when the power was calculated using various formulas, you can see that there is a huge difference in the IOL power calculation using your SRK formula, which is 5.5 diopters, and your SRK-T and Holiday 1, which is coming to 2 diopters and 1.5 diopter. So which IOL formula are you going to use in such a case? It was found that SRK-T and the optimized Haigis formula, it shows almost no difference. And another difference also confirmed the same thing, that the Haigis formula was found to be more accurate in predicting the post-operative refractive error in longer eyes, whereas the SRK-T was also equally accurate. So in such longer eye patients, it is better to go ahead with the SRK-T or the optimized Haigis formula. So just to conclude, that which is the right formula that you should use if your axial length is in the normal range of 22 to 24.5 millimeter, it doesn't matter which formula you are using because all of them are going to provide you the same IOL power. In very short eyes, which is less than 19 millimeter, the Holiday 2 provides more accurate result. In eyes which is less than 22 millimeter, Hoffer Q provides a more accurate result. In eyes which are up to 26 millimeter, the Holiday 1 is going to provide you a better result. In excessively longer eyes, which is more than 26 millimeters, the SRK-T will provide you a better result. Whereas you have a newer generation formula, a newer formula that has come, which is the Barrett's 2 formula for very high myopic eyes, which is quite accurate. So it is important that whenever you see your patient next time who has come for the cataract surgery, you have to see the axial length, the normal range, the difference between the two eyes, the keratometry of the patient, what is the difference in the K1 and K2 of each eye, and then decide the IOL formula that you will be using accordingly. Thank you.
Thank you, Dr. Kesha, for axial lens. So the IOL Master 700, which has the Barrett suite, has the Barrett's Universal 2, Barrett's Toric, and the Barrett's 2K. So Toric is for the Toric IOL calculation, and 2K is for the post keratorefractive surgery patients, post RK patients, post LASIK patients. So Barrett's Universal 2 is applicable for all axial lens.
Now I would like to invite Dr. Parul for a talk on types of intraocular lenses.
Good morning. Today I would like to discuss the types of intraocular lenses. So the evolution of IOLs was initially by Dr. Harold Ridley. He observed that when the splinters of acrylic plastic material from an aircraft cockpit canopies became lodged in the eyes, they did not trigger an inflammatory reaction, as did the glass splinters. So cataract surgery has a history and evolution. Initially, Ridley implanted the first posterior chamber intraocular lens. Then the earlier anterior chamber lenses arrived. Then were the iris supported lenses. Then the intermediate anterior chamber lenses. Then improved posterior chamber lenses. And now the modern posterior chamber lenses. So smaller incision sizes are we are encountering with improved technology, and this results in decreased post-operative astigmatism. And now we have the femtosecond laser also to make incisions which are highly accurate. So we describe the terminology. The central portion is the optic portion, this portion. And the sides are the haptics. These are the haptics. Now we come to the IOL classification. So it depends on the destination where you are planting the IOL. That is in the capsular bag or the sulcus or in the on the iris, or you are scleral fixating the IOL, or you are putting the IOL in the angle. The overall design can be 3-piece or 1-piece. The overall length can range from around 10 to 13 millimeters. Nowadays we have most foldable IOLs around 13 millimeters. The optic material can be PMMA, or it can be silicone or hydrophobic acrylic or hydrophilic acrylic. The refractive index can vary from 1.42 to 1.55, and the optics shape is mostly biconvex these days. Optics diameter is mostly 6 mm these days, and this optics design, mostly we prefer the aspheric optic design. I'll discuss why. And the optics color can be transparent or it can be tinted with a yellow chromophore, which is mostly the blue light blocking chromophore. And the haptic properties, they can be 3-piece or 1-piece haptics. They can be PMMA haptics. And we now are having packaging as preloaded or not preloaded. So the Clarion IOL by the Alcon is preloaded, and many other IOLs are also coming up. So the major classification includes the lens material, the lens design, and the refractive index. So thinner the higher the refractive index, thinner the lens. Silicone characteristics, it was the first foldable IOL material. It was hydrophobic with low water content and low refractive index. That means it was thick. It had a fibrotic response to the capsular bag, and it was incompatible with silicone oil. So avoid silicone oil with silicone IOLs, or rather avoid the silicone IOLs to be put in eyes which are predisposed to retinal detachments. So these are the silicone IOL designs. Then we had the hydrophilic acrylic material, which had a hydrophilic surface with a high water content, and it requires hydration during the packaging. It has a low refractive index and high rates of PCO. And it has a potential for anterior capsular phimosis, and it even stains with a trypan blue capsular staining dyes. There are also reports of calcification and potential for striae from the PMMA haptics. These are the hydrophilic IOL designs. Then is the hydrophobic acrylic, which has a lower water content and it has a higher refractive index. That means it is very thin. It has slower unfolding as compared to the hydrophilic lenses, but it has a greater adhesion to the capsular bag, more tackiness, that is more adhesion to the lens surface. So that prevents PCO. These are the hydrophobic acrylic IOL designs. Haptics I have discussed. They can be 3-piece or 1-piece, and they can be C-shaped or J-shaped. C-shaped, C-looped is seen in mostly the AMO type of lenses, that is the Technis in the sensor, and the J-loop are seen in the Alcon lenses like the MA60 AC. So the IOL manufacturing can also play a role. The lath cutting is very accurate, and the OptiEdge design is a propriety of one IOL brand, and that prevents PCO. This is the OptiEdge design. The rounded anterior edge, it scatters the light and reduces the internal reflections, and the sloping edge minimizes the glare, and the square posterior edge, it facilitates a 360-degree capsular contact, prevents PCO. Now we come to the abrasions. What are the most important abrasions to consider? The spherical and the coma. Spherical is the 4th order abrasion, and coma along with the trefoil is the 3rd order abrasion. So human eye cornea has positive spherical abrasion and very low coma abrasion, which is usually corrected by the lens itself when young, but it is lost as we get older. So in a young eye, the cornea has positive spherical abrasion of plus 0.27 and the young eye is a negative spherical abrasion, the young eye lens. So they cancel each other. In the older eye, the cornea is positive and the lens also becomes positive. So the average spherical abrasion increases in an older eye. So when we remove this lens, we try to put a negative spherical abrasion lens, that is a aspheric lens, so that it cancels the positive spherical abrasions of the cornea and we have a better vision and better contrast sensitivity. So this I have already discussed. The marginal rays, they focus in front, and the paraxial rays, that is the central rays, they focus behind. This leads to spherical abrasions. So in spherical IOLs, the positive spherical abrasion of the lens will add up to that of the cornea and it will lead to this type of an image. In IOLs which have zero spherical abrasion, that is nil, like in Bausch and Lomb lenses, it will not cancel out the positive spherical abrasion of the cornea, so the image will be like this. And in the aspheric lenses, that is the negative spherical abrasion lenses, it will cancel out the positive spherical abrasion of the cornea and we will have a clear contrast, clear image as seen in this case. So this is how we see a patient sees when there are lots of spherical abrasion. It softens the contrast and blurs the details. And how do we measure these abrasions? We measure it by the MTF, which is measured using the eye trace. So MTF is a modulation transfer function. It demonstrates the ability of the lens to produce a high quality image with high contrast. So ideally the MTF should be like this, and the point spread function should be a single sharp dot. This is seen in the eye trace machine. And degraded MTF will have a lower contrast and lower image quality. So this is how we see a degraded MTF, and the point spread function is also big. So the higher the MTF contrast, the better the image quality generated by the lens. So reducing the abrasions increases the MTF. So our aim should be to reduce the abrasions. We come to the specific lenses also. So the Alcon lens, it is a L-shaped. I discussed C-shaped and L-shaped. So this is L-shaped. It has a refractive index of 1.55 and it has a posterior aspheric surface. The sensor lenses, they are can be single piece or three pieces, and they have a tri-fixed 3-point fixation, but they are not aspheric, non-aspheric design. The Technis one piece has a aspheric anterior surface. So they propose that this has the highest Abbe number. Abbe number is around 55 in the Technis group of lenses, and this leads to less chromatic abrasion. I will discuss the chromatic abrasion also later. And it has a 360-degree posterior square edge and a lathe cut design to reduce the vacuoles and the glistening. Toric IOLs are used in regular bow type of astigmatism, and they are the best candidates. So you see these marks on the IOL, they are used to align with the steep axis. So they are contraindicated in the corneal disorders requiring keratoplasty in future in cases of bag instability and zonular weaknesses. Now we come to the multifocal IOLs. Multifocal IOLs consist of multiple zones of lens power that produce more than one focal point, allowing for enhanced vision at both near and distance. So the aim is to get spectacle independence post-cataract surgery, independent of the ciliary body function. So there are three types: refractive, diffractive and mixed. So multifocal refractive, like the rezoom and the array, they create multiple focal points that allow viewing for all distances. They have zones at different curvatures. So there is different curvature all along, and they create different focal points at near, intermediate and distance. They can be symmetric or they can be asymmetric. These are the symmetric refractive type of multifocal IOLs. The distance vision is in the center, and then the near and then the distance. So there are basically zones in this. There are no gratings on it. In the diffractive, we have gratings. We have borders, discrete borders. So diffractive IOLs like the Technis and the Restore, they create two distinct images for near and far. They have concentric rings. Refractive don't have rings, demarcated rings. They create a diffraction pattern, but their disadvantage is that they don't give intermediate vision. So for that we have now got the trifocal IOLs, which give the intermediate vision also. So in diffractive also we have two types: the fully diffractive or the partially diffractive. The fully will cover the whole optic like this, and the partially will be covering a part of it. So what are the diffractive optics? What is it based on? 40% of the light is for the distance, that is the zero order, and 40% is for the near order, that is order 1, and 20% light is lost. So the width of these gratings, these are the gratings. So less the difference between the, less the width of the gratings, more the add. More the width, less the add. So there is a concept of apodization. What does apodization means? Reduce the height of the steps. So initially the steps are very tall, and then they decrease by around 200.2 micron every time, and this shifts the light energy split towards the far foci. So it helps in distance vision when the pupil dilates. When does the pupil dilate? During mesopic conditions. So during mesopic conditions, the pupil will dilate, and these rings, because their height has decreased, the light is shifted to the distance foci more. So this apodization is used in diffractive IOLs to decrease the pupil dependence of the IOL. Now we have a new IOL design which has the echelette design, which is which creates an elongated focus. So instead of apodization, it has these gratings, but it creates an elongated focus. So also it decreases the chromatic aberration. So what is chromatic aberration? The blue wavelength is the shorter wavelength, so it converges in front, and the red is a longer wavelength that converges behind. So this leads to chromatic aberrations. This IOL will it will not have any, it has a achromatic technology, so the chromatic aberrations will be diminished. So all the lights will converge at one point, as seen in this figure. So this is typical of the Symphony IOL. So what are the problems with multifocal IOLs? There can be glare, halos, and decreased contrast sensitivity. So the idea of multifocality was given by John Pierce and Hoffer. And what are the unmet needs of traditional multifocal IOLs? They lead to photic phenomena, decreased depth of focus, and poor patient satisfaction. So now we have evolution of the newer presbyopia correcting IOLs. Initially we had the refractive, then we had the diffractive, now we have the trifocal, and now we also have the extended depth of focus, and along with the hybrid multifocal and EDOF platform. So refractive was, you remember, array and rezoom. Diffractive was restore and Tecnis multifocal. Trifocal is now AT LISA or the PanOptix, which they also claim is the quadrifocal. And extended depth of focus is the Symphony or the Vivity. So Vivity is non-diffractive EDOF, and Symphony is diffractive EDOF. And hybrid is Synergy, which has a multifocal plus the diffractive EDOF combined into one. So these are the types of presbyopia correcting IOLs. So I've discussed all these. So PanOptix has the trifocal technology, which has the Enlighten vision. It is proprietary of their company. The Alcon Vivity is a non-refractive EDOF. The iHance is the refractive EDOF. So it increases the power within a central 1 mm diameter and provides intermediate vision. The Symphony is a diffractive EDOF. Diffractive means it will have these rings, but it will be extended depth of focus. So it will provide a full range of vision with reduced halos and glares as compared to a proper diffractive IOL. It has a achromatic technology. Synergy has EDOF with diffractive multifocal, so it is a offspring of Tecnis multifocal and Tecnis Symphony. And we have the light adjustable lens, which was FDA approved in 2017, not in India right now. So 2 to 3 weeks post surgery, the IOL power can be changed. This is the light adjustable lens, so it has photosensitive silicon macromers. We have the accommodating IOLs, that is a Crystal lens and the True Line, and they can be single optic or dual optic. Crystal lens is a single optic. It is made of silicon, so it is avoided in patients of asteroid hyalosis and patients who require retinal surgery with silicone oil injection. So this is a single optic IOL. Then we have the dual optic IOLs, and the upcoming IOLs include the liquid lens, in which there is a liquid. In the lower third, there is a lower refractive index, which leads to distance vision, and in the upper 1/3, when the patient looks down, there is a higher refractive index liquid, so it is used for near vision. This is the fluid vision IOL, implantable miniature telescopes. smart IOLs which remodel with heat and body temperature. And then the AcuFocus or the IC8 small aperture lens, this is same as the cornea inlay, that is a camera corneal inlay, to extend the depth of focus via pinhole effect. Thank you so much.
Thank you, Dr. Powell, for such an informative and detailed talk on the types of IOL. So there's a slight change in the session schedule. So the next talk by Dr. Gagandeep would be taken up in the next session. So with this, we would be winding up our session on the basics, and we would be moving on to the next session, that is phacoemulsification, pearls for a perfect outcome. I would like to invite Dr. Jitendra, Dr. Arya, and Dr. Suresh, and Dr. Jaspreet to kindly chair the session.
Good morning, everyone. Welcome to this next very important, very interesting session that is Pulse for a Perfect Outcome. So for residents, it's very important because cataract learning is the most important part of your learning in your post-graduation. So this session is going to tell you about various pulse. So listen very, very carefully by the experts on various cataract techniques, various types of surgeries. So first, I request Dr. Suresh Kumar to present his top 5 pulse for hard cataract. So managing the hard cataract is one of the challenging situations. So how to use various parameters in the machine and how to get best outcome by using the best techniques of phaco. So I think that Dr. Suresh is going to tell.
Very good morning to all. Thank you for this session. Very few in last 2 decades. But unfortunately with COVID pandemic, all of us are encountering few hard cataracts nowadays. So just like any other cataract surgery, we have to pay attention to all these factors while evaluating and performing the surgery. And in ocular examination, if there is any relative afferent pupillary defect, it has to be documented and it indicates poor prognosis. But still surgery has to be done because of either cosmetic reasons or to prevent complications like phacolytic glaucoma. And if you see brown or black pigment on slit lamp evaluation, this directly correlates with the hardness of the cataract. And ultrasound B scan must be done to evaluate posterior segment in these cases, and your specular will tell us the status of endothelium. And a number of surgical options are available, but I'll be focusing on phacoemulsification. And choice of anesthesia, I normally use topical in most of the cases, but in some cases you should not be hesitating in going ahead with peribulbar if you feel that patient is not cooperative, or you will be requiring excessive manipulation, like pupil is also little myotic or less likely to dilate as in diabetic patients. And general anesthesia may be required if patient is very, very uncooperative or have some psychiatric issues. And the most important step in cataract surgery, especially in hard cataract, otherwise also, it's the capsulorhexis. This is heart of this surgery. So capsulorhexis has to be very good. It has to be well centered and adequate size. If you make a small rhexis in hard cataract setting, you are inviting trouble. There will be more stress on the zonule. So we should avoid smaller rhexis in hard cataract surgery. And always stain, because in retroillumination you don't see any red glow in these patients. So you have to stain the capsule so that it's visible and you are able to perform good capsulorhexis. And most of these cases will have liquefied cortical matter, and once you make a puncture, the liquefied cortical matter starts coming out. So there is high intralenticular pressure. So sometimes you have to aspirate that white cortical matter to make the capsule visible so that you are able to complete the rexes, or you can use high viscosity viscoelastic like Helon GV, so that will flatten the anterior lens surface, and then you can go ahead with good capsular rexes. And sometimes your capsular rexes forceps, microincisional or microincisional scissors may be helpful if you have a plaque on the anterior lens capsule. And small video showing capsular rexes in a patient with white and hard cataract. So I started with 26G cystotome, but soon it started running out. So then I shifted to forceps and completed the rexes. So I think we should, I will prefer forceps over cystotome in these cases. Then next step is hydrodissection, and as there is hardly any spaces in hard cataract, so the chances of blowout is very high, so you have to do minimal hydrodissection, and we have to go at multiple places, go through your main port, side ports, inject minimal fluid, and the moment you are able to rotate the nucleus, stop, otherwise you can have blowout, and your pupil will constrict if there is posterior capsular rent. And if you are attentive, you can pick up it immediately. So this is multi-quadrant hydrodissection. Then pupil management will be covered in another lecture. I will be just sharing few tips. And if they are combined hard cataract and small pupil, it's a very big challenge to the surgeon. And if you are anticipating intraoperative floppy iris syndrome, then pre-treatment with atropine may be beneficial. And then intraoperative phenylephrine or high viscosity this viscoelastic device, it may aid you in surgery in IFIS syndrome patients. So this is a patient who had trauma in the past leading to adherent glaucoma formation, and he had small pupil, and unfortunately patient came late with hard cataract. So this is a recipe for disaster. If you are not careful, then you can have problems. So if you have small pupil, so if you have small pupil with soft cataract, you can still, go ahead without dilating. But if you have a hard cataract, you have to dilate. You have to use devices, either iris hooks or whatever device you are comfortable. Don't be lazy, always use, then probably you can manage even hard cataract. Then zonular management in these patients. Again, iris hook which we are using for iris dilatation can be put into the margin of the rexes. So if you have a smaller dialysis, less than 1 quadrant, 2 quadrant, then probably you can manage with iris hook also. Otherwise CTR, or you can have capsular segments, they can be used in conjunction with phacoemulsification. Then another most important part of surgery after capsular rexes is your nucleus management. So what are the challenges in a hard cataract patient? It's the adherent lens fibers, and there is hardly any space within the nucleus. It's a dense cataract, so you are not able to put chopper anywhere. So that creates problem. And there is no cushion. Normally, otherwise, when you are dealing with soft cataract or other cataracts, you always has a cushion of cortical matter which saves the posterior capsule from phaco-tip. But in these patients, you have to be little more careful. So then these are all cracking techniques which can be used in managing nucleus in these patients. You can have vertical chop action, horizontal chop action, then tilt and crack technique, or decrease and concur, again because nucleus, entire lens is in the form of nucleus and it's bulky, so there is hardly any space in the anterior chamber, so you have to debulk. So remove central core and then go ahead with whatever technique you want to follow. So you have terminal chop technique also. So if you make your paracentesis incision for chopper around 1 1 to 2 clock hours, around 2 clock hours from the main port, then you have more this chances of cracking the nucleus. So always debulk some central core nucleus. It will provide you working space. And another very important thing is you have to adjust or modulate the power. So if it is a very hard cataract and you are using lesser power, you are putting strain on the zonules. So increase the power when you are able to create a crater comfortably. That's the power which is required. Go ahead with that power, and then you will be able to manage your cases comfortably. Otherwise you will be struggling and struggling. So then we have to customize fluidics and power used during every case basically. So depending on the density, hardness, you have to adjust. And pulse mode, burst mode will give you advantage that they are only used for certain period of time. So in between that time you are not using energy, so your endothelium is safer. And if you are lucky to have torsioner or elliptical phaco facility in your phaco machine, so then you will be little more efficient. So then showing a video of my patient. This patient also had small pupil, and I have used iris hooks to dilate. So if you are just embed the tip in the center and try to pull gently, and if you are able to see the edge of the nucleus, put your chopper there and divide. So keep on dividing multiple. The harder the nucleus, more fragments you can make, and then ultimately you remove these fragments. And if you take your chopper behind the equator, so then probably you will get complete chop. If you are superficial, you won't get deep chop. Your posterior plate will always be intact. So this is another technique which this is the same video, sorry. So this is terminal chop. You have a specially designed chopper, which is known as terminator. So it is a curved like hook. So you go behind the equator and then you do the horizontal chop. So it will give a crack in posterior plate also. So even in very hard nuclei you can manage them with terminal chopper. So rest of the steps are same as in any other phacoemulsification procedure. So then this is the technique which I call flower petal technique. This is most commonly used. In majority of patients we are doing this. So you go at the center and try to make multiple cracks. These cracks won't go to the posterior plate. Posterior plate is still intact. So it's like a flower petal appearance. So then debulk the center and then tackle individual petals partially. Central core is still intact, and in the end you can bring central core little anteriorly and complete the phacoemulsification. So take home message from my talk is careful attention to preoperative workup will make your surgical outcome better, and you have to modulate your power and fluidics during the phacoemulsification depending on the hardness of the cataract, and capsular axis has to be of adequate size. And then nucleus management has to be as per surgeon's comfort. Don't follow what I am showing. If you are not comfortable with my technique, devise your own technique and follow that. Don't be under pressure that I have to follow some particular technique. Then you can have issues during surgery. Thank you. I'm thankful to Dr. Ujjwal and Dr. Sanchi for helping in this preparation of this presentation. Thank you very much.
Thank you, Dr. Suresh. Any question from the students? Any doubt? I think Dr. Suresh, 200 tips. One thing you must remember, whenever you are operating in hard cataract, people must be fully dilated. If it is small, people never do it. Put some hooks, because then you will be in trouble if you are doing small people with hard cataract. The other thing is proper rexis. And the rexis size also should be larger than normal size. Because if it is small, then tackling will be difficult. So take a little bit bigger rexis size. Then as per your comfort, whether stop and chop or direct chop, divide and truncal, whatever technique you are comfortable, one can go accordingly. So it is basically choice of the surgeon how to operate in hard cataract, but these basic simple things Dr. Suresh shown by videos, so that you must remember. Thank you, Dr. Suresh.
Thank you.
I request Dr. Gagandeep to come on the dais, please. Next one. I think Dr. Gagandeep is going to present his pending talk. So from previous session there was one talk, next generation of monofocal and innovative technology to change the standard of care. Dr. Gagandeep is a very reputed phaco surgeon in North India. Basically earlier he was in PGI, now working his own practice. So very wonderful phaco surgeon. He can do any type of phaco surgery. So we are very lucky to have Dr. Gagandeep to listen to him. So first he is going to tell about various next generation monofocal IOL, and after that I think later on we will speak on some other topic. That will speak later. Dr. Gagandeep, please.
Arya, at the outset, apologies for being late. It's a working day, so I had the OT in the morning. And thank you, sir, for your kind words. He is very liberal with his words, some of which are not true. So my talk from the previous session is on a new generation monofocal. Essentially, we have a lot of these new lenses, the monofocals which are coming in. These are known as the monofocal plus or the new generation monofocals, because over a period of time everybody realizes that there are issues with the multifocals or trifocal, most of which are being used are refractive IOLs, and they have their own issues of reduced contrast sensitivity and glare and halos during night time. And the world is trying to use some of the spherical aberrations, revisiting the spherical aberrations in trying to give the patient better pseudo accommodation, and also trying to minimize the nighttime issues and the issues of glare and halos with these IOLs. So I'll actually be touching upon one particular IOL, not a host or a series of these newer generation IOLs. I'll be talking about the words and my experience with the Technis iHands, which is a monofocal extended depth of focus lens. Some people may not consider it an extended depth of focus lens, but generally everybody realizes that the landing zone or the defocus curve is a little flatter than a standard monofocal. And obviously patients want clear vision after cataract surgery. And you have all seen a very old slide. What does 20 by 20 mean? Because 20 by 20, when the patient reads a particular line on the Snellen or the logMAR chart, that may not actually be the total quality of vision that the patient is seeing. There may be slight, kind of a shadow along with that each alphabet or letter, and there may also be a reduced contrast, as you see in some of these blocks here. And again, a very old slide, when the first generation aspheric IOLs came in, the general idea was to improve contrast sensitivity and try to balance the corneal asphericity with the negative asphericity on the monofocal IOL. And also address some of these issues, because the diffractive multifocal IOLs were available or have been available for almost 30 years now, and most of them have had issues with nighttime driving essentially. And like I said, the presbyocular correcting IOLs, we have the multifocal IOLs, and now there is a renewed interest on using spherical aberrations to improve the depth of focus. And in between, we also had the availability of some accommodating IOLs, but somehow they did not provide adequate levels of pseudo accommodation. So generally most of the accommodating IOLs in today's time are really a historical perspective. Now these extended depth of focus or extended is more like an extended depth of field, please pardon that thing there. It has a single elongated focal point rather than multiple focal points that we have with the multifocal IOL. And aim, like I said, is to reduce some of these photic phenomena, and it also may be combined with the diffractive platform, which we had the Johnson & Johnson Symphony, which was the first extended depth of focus IOL available. And when we talk of an EDOF monofocal IOL, it avoids the overlapping distance in near images that we have with a multifocal IOL, and thereby reducing the glare and halos. But the increasing depth of focus, again, please excuse the field, may have a trade-off in reduced contrast and visual acuity. So to have something available, you will actually sacrifice a little bit of quality on the other side. These lenses have better image quality than multifocal IOLs. And like I said, because of that trade-off in the contrast and the distance vision quality, usually these lenses will not have more than one diopter range of focus. If we increase that range of focus, we start getting into the problems that we had with the refractive multifocal IOLs, which were available many years back. And we all know, especially the students need to know this, that some of these higher order aberrations, they do improve the depth of focus, and this is the principal mechanism employed by the EDOF IOLs. And some of these IOLs, they also have improved or reduced chromatic aberrations. Some of these lenses have that, and that helps to mitigate some of this contrast loss that you have with the EDOF IOLs. Now people have proposed a classification of these extended depth of focus IOLs. One side is a pure extended depth of focus IOLs, which may be spherical aberration based or pinhole based. And then we have the combination with multifocal IOLs. And there's a chart which is there. I'll be essentially talking about the Eyhance, but there's this newer IOL I have no experience with, the Alcon Vivity. Some people may have had experience with that. That would also be placed somewhere in the pure EDOF IOLs. They have their own technologies, and in general, this group will have, the pure EDOF IOLs will have lesser nighttime issues, lesser glare and halos than when we combine them as a hybrid with a multifocal. Now the Eyhance essentially has a continuous power profile increase from the periphery to the center of the lens, like you see here. It's a gradual change, and the whole lens is essentially based on the Technis platform only. And when you look at the lens, it is indistinguishable from a regular monofocal Technis. You can't actually tell the difference. It also reduces the spherical aberration just like the Technis monofocal. But what the lens has is essentially as a continuous increase in power from the periphery to the center, and a central about 15% area which has a further near add, which in my experience is at best about 0.75 diopters. And the proprietary aspheric optic creates a continuous power profile to enhance, essentially, because when I said 0.75, it will essentially improve intermediate vision, provided your distance vision is, unaided distance vision is good. And like I said, the difference in the surface is essentially undetectable compared to a Technis monofocal. And what people have seen around the world as that the performance of this lens is practically the same as far as nighttime contrast and halos and glare is concerned, almost the same as a Technis monofocal. So it's a very forgiving lens. You can actually use it in place of a monofocal aspheric IOL. And in my own practice, I don't use the Technis monofocal now at all. The total inventory has been replaced by the Eyhance, because this is to my mind a more forgiving lens. Even when you have some biometric errors, because it has a wider so-called landing zone, it is more forgiving for small biometric errors. And the eye is equally tolerant to decentration of this lens vis-a-vis a standard monofocal eye. And this is essentially company data. We observed that the glare, halo, starburst were very similar between the standard monofocal and the Eyhance here. So for all the three, halos, glares and starburst. And it has been a similar experience with other authors as well. And here is a study of about 80 eyes, and they observed that uncorrected and corrected distance and near visual acuity was similar between the Technis monofocal and the Eyhance. But monocular and binocular uncorrected intermediate vision was significantly better with the Eyhance. And they had no difference between them as far as some of those issues that I had already discussed. Another study, again 64 eyes, and they tried to look at some of these parameters and found that the Eyhance provides a significantly better intermediate vision than a standard monofocal, and a flatter defocus curve. This flatter defocus curve is what allows you a little more freedom when you actually calculate for each patient. And the other study, the second study, also did not notice any difference between the two IOLs as far as contrast and other photic phenomena is concerned. And a study from our own city, also published in the Indian Journal, compared the defocus curve between the Technis monofocal and the Eyhance, and the Eyhance had a flatter defocus curve, and it not only provides distance but intermediate vision as well. So the conclusion and key takeaway from some of these newer IOLs which are coming in is these things: we need intermediate vision, and if we can give it to our patients without the problems associated with multifocal IOLs, then this is a good trade-off with the problems that some of these EDOF lenses may also have. Those are not very marked. So these lenses, they perform quite well and are quite safe to use. So practically all monofocal IOLs monofocal IOL patients can actually be implanted with the Eyhance. And the improved functional vision can be achieved even without a micro-mono kind of adjustment. If you want to actually give the patient more pseudo-accommodation, this lens will allow you to achieve more pseudo-accommodation with mild to moderate difference between the two eyes, and the difference will be less than when you try with a standard monofocal IOL. Not many of us practice monovision, but again this IOL will help you if you are going to practice monovision as well. And obviously a lot of studies are showing that they improve patient satisfaction. Thank you for your patient hearing. This is one such IOL. A lot of these IOLs are coming in, and some of us will have experience with some other IOLs as well. Yes, I have the second talk here as well.
So we are going to speak on top 5 for posterior capsular lens management. So whenever we are doing any cataract surgery, so there will be one way or the other some PC lens. So PC lens is not an issue. So one should know how to manage the PC lens. So if that is managed nicely, so you will not have any visual complication. So this is very important to know how to manage post-capsular rent. So Dr. Gagandi, please.
Yes, Dr. Arya touched upon this very important intraoperative problem that most of us will face at some point when we operate. And for all of us, it's a dreaded complication, and it signals the end of a good phaco. So after you have a rent, you are essentially trying to salvage good vision in that eye with least long-term problems. And it is not uncommon. It will happen to all of us. And when you are a resident or when you are less experienced, obviously the incidence will be higher. And as you gain experience, you will slowly get the better feel of surgery and reduce the chances of posterior capsule rent. But you'll never be able to eliminate, because the day you think you are a great surgeon is when you actually land up with a PCT. And once you have a tear, you can have a lot of issues. These are just 2 issues listed here. You can have a drop into the vitreous cavity, which is what you want to prevent when you're trying to deal with a intraoperative PC tear. And obviously, you can have a compromise in the IOL placement. Now, what are the predisposing factors? I've kept the first one, and I think that's the most important, is surgeon inattention. When you are concentrating on something else and not noticing what else is going on in the eye is when you actually land up with a problem. And some of these other things, small pupils, posterior polar, very hard or very soft cataracts, yes, these things can happen, but these are patients you do not select in the beginning at all. So you have to stay away from these group of patients in the beginning to try and minimize the risk during surgery. This would be for more experienced surgeons. When we have these kind of cases, obviously the incidence of intraoperative complications, it rises. And there may be at times pre-existing PC tears as well, especially when associated with trauma or posterior polar cataracts. So you have to carefully examine these cases to look for a pre-existing opening. Now, this is probably the most important. How do you recognize PCTR? And it is very important to recognize it in time, because if you don't realize and you continue, that's when you have the more serious issues and the nucleus drop, which I talked about. One very important sign is the pupil snap or pump sign. The moment you have a PCTR and you have a vitreous loss there, the pupil tends to snap. It gets mewled and then again it gets dilated. So you need to look for or be aware of a pupil snap sign and a sudden appearance of a very clear red reflex. Sudden deepening of the anterior chamber. An anterior chamber which is irregular depth. It is shallower in one part and deeper in the other. And the next one is inefficient phacoemulsification. There is a fragment in the anterior chamber or just outside the band, and somehow it's just not getting emulsified. It must warn you that there might be vitreous there, which is preventing efficient phacoemulsification, even when everything else is normal, your machine is set up all right and everything. A clear gap emerging between the CCC margin and the nucleus. When you started surgery, the nucleus was almost abutting the undersurface of the CCC, but suddenly the nucleus and the CCC have a clear gap in between. The nucleus has descended a little. That's when your antenna must be high up. And again, this will happen when there is a slight tilting of the nucleus within the band. And the final is the feel. As you do more surgery, you realize this is not proceeding well. There is something wrong here. The moment you have that, you must stop. but not bring out your phacoprobe. The topic given was 5 points to remember. You can stretch it to 5 points here. They would be don't panic, don't panic, don't panic. This happens to everybody, and there is a way out to save the eye from serious problems down the line. Now, what will be the management strategy for small localized tears where there is no vitreous prolapse or maybe a little bit of vitreous prolapse? These small tears may actually be converted to a posterior CCC. But then again, this is once you have experience. In the beginning, this is not what you will be able to achieve. Large tears, as far as the IOL fixation is concerned, you will then have to come back to sulcus fixations or TSF IOLs or AC IOLs. Anterior vitrectomy will have to be performed in practically majority of cases. When I say without vitreous loss, there will be very few cases where there is breakage of just the posterior capsule and the anterior hyaloid face is intact. Most of the time, both the events have already occurred together, and you will need to do a good, clean anterior vitrectomy. When I say anterior vitrectomy, it is anterior to the posterior capsule. You don't need to go into the vitreous cavity to take a lot of vitreous out. And some, in interest of not creating more problems while you are trying to handle a PC tear, some amount of cortex or nucleus may actually be left behind and observed for a later development of uveitis or pressure rise or something, where you can actually go in and remove in a second sitting if something like that happens. So the recommended is that small amounts of nucleus, the nucleus is more toxic. So very small amounts of nucleus or epinucleus may actually be observed, and that's less than 5% of the total volume. But you can leave behind larger amounts of cortex. You don't need to go ahead and remove 100% and keep pulling vitreous and enlarging the opening. A little amount of cortex may actually be left behind and observed if that allows you better placement of the intraocular lens and not intervening more than it is necessary. Now, I already touched upon you should not remove the phacoprobe. The moment you realize something is wrong, the first reaction is to come out of the eye, because the moment you come out of the eye, the chamber will actually shallow, and that will increase the size of the posterior opening and allow more vitreous to come into the anterior chamber. You need to tamponade with viscoelastic. So the first thing you do is go to foot switch position 1, which is just irrigation, and then you start putting viscoelastic from the side put with the other hand. And as the viscoelastic goes in, some of it also comes out because this irrigation flow in the eye. But once you have an adequate amount, then you go to foot switch position 0 and come out. This whole balance is to not let the anterior chamber shallow while you are coming out of the eye. Very important, this last line is extremely important. Going behind behind the level of the posterior capsule is an absolute no-no for an anterior segment surgeon or a cataract surgeon. You don't want to put wire vectis into the vitreous cavity to remove fragments. You don't want to put the phacoprobe in the mid-vitreous cavity trying to emulsify. That's an absolute no-no. So all that you are allowed to do is an anterior vitrectomy, remaining mostly up to the pupil or the anterior capsule level. Don't go beyond that. Now I said these could be two events, which is opening up of the capsule and opening up of the anterior hyaloid face. Most of the time they will happen together during the phacoemulsification part. But rarely when you are doing an IA, and you happen to rip or tear the posterior capsule, in some of those cases the anterior highlight face may still be intact, and you need to recognize in time and do the same steps which I listed earlier. That will allow you to get away without an anterior vitrectomy and give you, a stage where you can actually better place a lens in that case. This again, I mean, even if it is not intact, you put viscoelastic from the other side, convert to a CCC if that is possible. You may have a senior surgeon with you at that point of time. You may paint the capsule with a trypan blue dye even at that stage. Convert to an ECC if you think there's a large nucleus piece in the eye, it's going to be hard to remove it otherwise. But if a part of the nucleus is there, you can actually push the vitreous back with viscoelastic and remove over a sheet slide or what is known as an IOL scaffold. You can actually put a 3-piece IOL behind those nuclear fragments into the sulcus and then do a gentle phacoemulsification for those fragments in front of the IOL. If there is a partial luxation, you could actually save the nucleus by the use of a spatula. But again, when you use a spatula or a wire vectis for a large nucleus, you are again remaining almost at the pupillary level or maximum anterior capsule level. You don't want to go into the vitreous cavity and scoop out material from there. If the nucleus begins to descend, avoid expanding the defect and pushing the nucleus even more posteriorly by your movements going in and outside the eye, getting the anterior chamber getting more shallow, and never chase with the phacoprobe into the vitreous cavity. Tearing of the rhexis during IA. Sometimes you can have that, and at that point again use the same technique to prevent shallowing of the anterior chamber, and you can actually consider a dry irrigation aspiration or do something from the side pole. Now, a very old video, almost I would say 17, 18 years old, I was doing a small pupil uveitic intumescent kind of cataract, and this is something I used to do in those days. Once I had stained the anterior capsule and I was trying to do the CCC, at some point the CCC went radial, and once the CCC goes radial, then you have to be careful with the subsequent steps. If the radial extension is subincisional, usually that's more forgiving. But if the radial extension is here, where your active movements are going to be, which is in front of the phaco-tip, then the risk is higher that it will extend onto the posterior capsule. So while I was doing this, somewhere here is where it went radial here. I don't do these things any longer. I would do a very small CCC, a 2-stage CCC in intumescent cataracts these days, and I've also stopped doing this cutting of the CCC margin and then completing the CCC after giving a small nick, because you must remember you have converted the CCC in almost like to 310, 320 degrees, but you still have a radial extension there. You haven't got rid of the radial extension. So once you're a little more experienced, you can actually try the Little's maneuver and some of the other maneuvers in trying to get the rhexis back into the visible area and again have a complete rhexis. Safety of phacoemulsification is only possible if you have a complete rhexis. If you have an incomplete rhexis, as a student and somebody who is not very experienced, you should actually stop at that point of time. Don't try to keep on doing, because there's a high chance that you will end up with a PC tear. So you see here I am trying to remove the soft nucleus. There is no chop. I used to use a 0-degree tip at that point of time, and I will show you two mistakes which I did back then. One mistake you've already seen, that I had a radial extension, I cut it with the 1/2, and then did the rest of the CCC in the rest of the part. And once the epinucleus was out and everything, I didn't tamponade like I recommended earlier, that you put viscoelastic from the side. Try not to have the anterior chamber shallow there. I removed the phaco probe and the radial extension went on to the posterior capsule. So you have to be careful. Always, whenever you have any of these issues, don't let the anterior chamber shallow at any point during your surgery. So finally, removed some of these remaining cortex with a bimanual, and was able to place a 3-piece lens in the sulcus. But you see here the same radial extension has extended on to the posterior capsule. Happens very commonly. And obviously, when you deal with angry looking posterior polar cataracts, in some of those cases you will end up with the posterior capsule opening. The opening is actually already there in some of those cases. So when you do a suspected case, let's say, many of them may be simulating posterior polars. But whenever I look at a posterior subcapsular cataract, where I feel that it may have some element, I would rather manage it like a posterior polar cataract, not do hydrodissection and stuff, than get into a false sense of security and assume that it is a posterior subcapsular cataract and nothing will happen. So once the nucleus had been removed, we will see the same mistake again.
Dr. Gagan, I think if we can just...
I'm on the Sorry for taking too long. I get carried away.
Yeah, it's only 8 minutes talk from CBS. The whole tracks
Okay. So again, remove the probe, had shallowing of the anterior chamber, and had a PC opening, large PC opening, did an anti-vitrectomy but placed a lens in the sulcus, and look at the other eye, not managed very well somewhere else, and you have vitreous in the section, patient has cystoid macular edema and stuff. So concluding that the cataract surgeon role is to remove remaining nuclear fragments. Those are the toxic part. Remove prolapsing vitreous, securely place an IOL, close incisions and suture them if necessary. Don't leave a leaky or questionable kind of incision there. And always refer to vitreoretinal surgeon for an evaluation. And cystoid macular edema and retinal detachment risks are obviously higher when you have these complications. So to conclude, rent is not uncommon, it happens to all of us. Early recognition is what is important, and don't panic, and do only the recommended steps, and post-operatively you follow them up more carefully than you would a routine uncomplicated treatment. Thank you all for the
Thank you, Dr. Gagan, for a very excellent talk. Now I think he is working in pediatric ophthalmology in PGI, very excellent pediatric surgeon. So he's going to show very beautiful videos and important tips about pediatric cataract, because it's a very specialized type of cataract surgery. So Dr. just take this. Because of inauguration at 11:30, so there is some change of schedule. So the pending speaker they will be presenting after inauguration.
Thank you, Dr. Suresh, and of course it's a collaborative effort of NZOS and COS. So I won't take much time, and of course you had such a wonderful talk on cataract surgery and how to go about it, and Dr. Gagan is also a prolific pediatric cataract surgeon as well. So these pediatric cataracts are not hard in most of the cases. They are quite soft, so you just need an irrigation aspiration. But there are other things which matter, the pre-op management and the post-op management, those are very important. So I'll be just covering, it's the top 5 pearls, so I'll just cover the 5 basic things which the resident should know. So the management differs if you have a bilateral cataract versus if you have a unilateral cataract. The management differs on, again, surgery would remain the same probably, but it's just the planning of the surgery and your post-op management that might differ. So when do you want to operate the cataracts in children? So you want to do a surgery if it's visually significant, that means it's more than 3 millimeters, it's central, it's posterior, it's confluent. But yes, again, if you have a cataract which is not that dense but the child is having nystagmus or the child is having strabismus, probably you would need to intervene much earlier. So these are the controversies. So you still have a little debatable topics in pediatric cataract, like what is the optimal age when you would like to operate, what do you want to aim for, well, you're going to put an IOL and there's going to be a myopic shift. So what is your aim? How much undercorrection do you want, or do you want to leave the child ametropic? Do you want to implant an IOL or leave the child aphakic? Where do you want to implant the intraocular lens, whether in the back or you want to do a capture? If you want to do a bilateral same time surgery or do a unilateral surgery, and of course in an older child where you want to put a unifocal IOL or a multifocal IOL. So these are still topics which are still being discussed, and because of these probably I think some of the areas where we have a little bit of consensus, I would be just discussing and put them in the pearls. So the timing of the surgery, the pearl one was when to operate a child, the second is timing. So the best visual outcome is during the first 6 weeks of unilateral cataract. So unilateral you need to operate much earlier as compared to a bilateral cataract, which is 8 to 10 weeks. It's more related to patching and compliance. Again, I said it's the post-op management which does help in regaining a good visual outcome. Very early surgery, with that I mean less than 4 weeks. So with less than 4 weeks, when they have an immature, you can say renal function and plus other issues. So you have anesthetic issues also. Again, plus you have local ocular issues which are like glaucoma and inflammation. So the younger the child, more is the risk of glaucoma and inflammation. So the consensus is all non-essential surgery to be done after 4 weeks post-conceptional age. Now the third pearl is whether to leave the child aphakic or put an IOL. Now in Indian scenario, you would go in for IOL in maybe instances where in Western literature they might leave the child aphakic. So why is the IOL preferred here, especially in unilateral cataracts? It approximates the optics of the crystalline lens. Then of course it gives a full-time partial optical correction. So even if the child is not wearing the spectacles, probably some correction is being achieved. But yes, there is some limited data, but superior to contact lens in visual outcome. So again, Western and Indian literature differ. Contact lens advantages are power can be changed, and you can have a secondary IOL when the refraction is stable. So this is what the proponents say in the West, where you have the infant aphakia treatment study, that yes, you better implant an IOL, because what they found was that you have higher complication rates with the IOL as compared to a contact lens. So we did a prospective study and we found that in our study probably the visual axis of pacification, which was much higher in the infant aphakia treatment study group, was much lower in our study. Yes, the age of the patient does matter. They had patients who were lesser than 3 months of age. We had the patients who were mostly above 3 months, but yes, they were infants. So the pearl 4 is IOL power calculation. As I was saying, it's because there's going to be a shift, the axial length is going to increase. So what do you want to aim? An emetropic, or you want to have a myopia, or you want to have an hyperopia? So what's the optimal approach? Again, the refractive goal, how much is the myopic shift? It is all going to depend upon the age of the child. So if you have an infant, probably the myopic shift is going to be much higher versus if you have a 4 or 5 year child. So how much undercorrection you want to achieve? Definitely in an infant would be much more as compared to a 3 or 4 year old child. So remember, the axial length at birth is about 16.6 to 7, and you have a steep cornea which gradually changes over time. So most axial elongation occurs in the first 2 years of life, remember that. And the average myopic shift which has been observed is 6 to 7 diopters when you are operating on infants. So for infants, this is the amount of shift, so you might undercorrect about this much. So what the surveys predicted was that you have 4 to 6 diopters till 6 months. So you have an undercorrection of 4 to 6 diopters till about 6 months. Less than 4 diopters at 1 year and mild hyperopia, because the axial length won't increase that much. When you have anisometropia, do not have greater than 3 diopters because that's considered amblyogenic. So that is also one of the things. So that's what I said, the planning is more important. The surgery is almost the same, probably what you would do in an infant versus what you would do in a 3-year-old child. So coming to the last pearl, which includes surgical techniques, the way to go about the conventional way is do a primary posterior capsulotomy, do an anterior vitrectomy, and put an IOL in the bag. So that is what is to be done in a child as compared to what you would do in an adult. The best way to do a capsulotomy, manual posterior curvilinear capsulorhexis with a centripetal pull. Now, when is this indicated? Would you do it in all children, like you have a 2-year-old versus a 10-year-old? Probably no. Again, the age is very important, and this is one of the most common controversial questions. So, all cataract surgery, preferably under the age of 6 years, you would do a primary posterior capsulotomy. Above that age, you can avoid an anterior vitrectomy, but yes, you would still do a primary posterior capsulotomy. And other things are the condition of the posterior capsulate, whether it's dense, you have a plaque. Even in an older child, if you have this, probably yes. Or an uncooperative child, you're having a child with nystagmus, or you have a child with Down syndrome, probably you would still be doing that in an 8 to 9-year-old child. Because they have high rate of PCO, especially the infants, so, and those under 6 years of age, they have a much higher proliferative rate. So it's better to do a posterior capsulotomy and an anterior vitrectomy, because the anterior vitreous face is also quite reactive. So it's better to do a limited anterior vitrectomy in these cases. Otherwise, you're going to land up with a posterior capsular opacification, which is amblyogenic, and very young children you might miss it. It should be a 3.5 to 4 millimeters. Central ideal is have a circular shape. Anterior vitrectomy could be done either through the translimbal route, which you're usually doing, or you can use the pars plana or a pars plicator route. So this is just to show you, and probably one of my concluding slides, that this is like a 5-year follow-up. You have an IOL which is like well covered with the capsule. You still have florid epithelial cell proliferation, which probably are not coming to the center, but yes, just to tell you, even after doing a good capsulorhexis and a good anterior vitrectomy, this does happen. And if you hadn't done it, probably then it would just migrate to the center of the visual axis, and you would have a dense amblyogenic posterior capsule, a visual axis opacification. Always close the incision. Do not allow them to, because they are elastic. The sclera is elastic, so they are leaky. You use frequent steroids, again which postpones healing. So it's always better to have to suture these incisions and not leave them sutureless. So here I would like to conclude by saying that the refractive growth after IOL implantation in infants and children cannot be predicted. So if you are doing a biometry, it can just go haywire also, because the target refraction what you predict can be just a surprise when you do a post-op retinoscopy. But yes, in young children, undercorrection should be done, and the optimal time to operate children is 6 to 10 weeks. Unilaterals are 6 weeks. Bilateral you could wait for 10 weeks. Always do a primary posterior capsulotomy plus anterior vitrectomy in all those less than 6 years. And of course, primary IOL implantations in infants is now being favored. Thank you for your attention.
Thank you, Dr. Jasprit, for a very clear and lucid presentation, highlighting all the important points when we deal with this specialized group of patients. And pediatric cataract surgery can be very gratifying, much more than adult cataract surgery, because when you see the children grow up and doing so well, then you feel so much happier being a caregiver. I think we'll wait for the inauguration now, and maybe continue some of those leftover presentation afterwards.
A very good morning to the esteemed faculty colleagues of August Gathering. On behalf of Department of Ophthalmology, Government Medical College and Hospital, I heartily welcome all the dignitaries and the PG students to the inaugural function of the 10th Ophthalmology Postgraduate Teaching Program. I would like to request Dr. Sanchi to kindly give a floral welcome to our worthy Director Principal, Dr. Jaspinder Kaur. Now I request Dr. Mahima to kindly give a floral welcome to Mr. Jasbir Singh, Joint Director Administration. The department has been organizing the postgraduate teaching program twice every year, and we are extremely delighted to share that this is the 10th event of the continued PG teaching experience for our budding ophthalmologists. The program has witnessed an overwhelming response from the PG students all across the states from Haryana, Punjab, Himachal Pradesh, Uttarakhand, Jammu and Kashmir and Chandigarh. The program aims at covering all the subspecialties in ophthalmology and help postgraduates brush up their basics, while also it gives them an opportunity to learn all the practical pearls through various didactic lectures. However, the highlight would certainly be the program that would focus on the hands-on wet labs. So the session this time focuses on phacoemulsification on wax eye model, dacrocystorhinostomy on cadaver, phakic intraocular lenses and intravitreal injections. I would like to invite Professor Suresh Kumar, Head of Department and Chairman, Scientific Committee, NZOS, to kindly address the gathering.
Very good morning to all. Professor Jaswinder Kaur, Director Principal of GMCH Chandigarh and Chief Guest of the day, Professor Jaspreet Sukeja, President of our Chandigarh Ophthalmological Society, Professor Sudesh Arya, Co-Chairman of the program, Professor Padul, Organizing Secretary of the event, and guest faculty from PGI and my colleagues from GMCH and friends. On behalf of Department of Ophthalmology, GMCH Chandigarh, I welcome you all for today's function. That is postgraduate teaching program in ophthalmology, and as Dr. Tanu mentioned, today we are celebrating 10th postgraduate teaching program, and it all started around 9 years ago. I became executive of Glaucoma Society of India and their GIEP program, the Glaucoma India Education Program initiative of GSI. So under that program we planned a glaucoma workshop and AGV wet lab. And I still remember I went to Professor Sood, who was our head of department at that point of time, and he was very encouraging and sportive. And this is how it all started. And few years down the line, we added other subspecialty. It started as glaucoma program, and then we added retina, uveitis, cornea, cataract, all other specialty, and made it a 2 days program because it was difficult to cover all the subspecialties in one day. And then few years down the line, we made it twice a year program rather than once a year, in the month of April and in the month of December, because again difficult to cover all the things in 2 days. And now that's the complete ophthalmology teaching program, and this was possible with the support of heads of ophthalmology department of various medical colleges, especially in North Zone, that is Punjab, Haryana, Himachal, J&K, Uttarakhand and Chandigarh. And with their support we got very good response. And last year we had registration of 75 residents, including from Srinagar and AIIMS Rishikesh and Dehradun also. And in today's program also we have registered around 60 residents, and few are coming from tomorrow's program. And the main purpose of postgraduate teaching program was training of the resident in especially North Zone area. What actually happens in bigger conferences like national or international conferences, residents are nowhere in the scene, so they don't get enough time. So that's why we thought of starting a program which is exclusively for residents. So we are only registering residents, no other delegate is permitted. And main thrust of program is hands-on workshops and wet labs in all subspecialties and interactive sessions. And in today's program we have a wet lab on phacoemulsification, implantable contact lens for high refractive errors, and DCR on cadaver. Again DCR on cadaver with support from Professor Kanchan. This is the initiative of our department. We did it last year because no resident or junior faculty member is interested in doing DCR. with the emergence of eco-emulsification, no ophthalmologist want to see blood, so they moved away from DCR. So I wanted resident to learn and get motivated for tackling DCR also, because this is part of our specialty. And with this brief introduction, I welcome all of you again and wish this program and all the residents a big successful training session. Thank you very much.
May I request DP ma'am and all the dignitaries to kindly come up for the lamp lighting ceremony. May I now request God to kindly say a few words. Good morning, everyone. Dr. Jaspreet Sukheja, Professor PGI-MER and President of Chandigarh Ophthalmic Society. Professor G.S. Barar from Sangam Netralaya Mohali. Professor Suresh, HOD and Chairman of this program, Professor Aryan, Co-Chairman, Professor Parul, Organizing Secretary of this program, the guest faculty of PGI, HODs and faculty of GMCH, all the postgraduate students who have come from different states and staff. It is really heartening to know that the Department of Ophthalmology has organized this kind of a program and they have initiated. And I think Dr. Suresh has really said it all, whatever I had to say. It is such a good opportunity for the postgraduates to have a hands-on training. And hands-on trainings, usually in conferences, there are limited entries, so most of the students may not get the opportunity. So this is a very good initiative of the department that they are providing the opportunity to the postgraduates to have a hand-on training. So Department of Ophthalmology deserves all the appreciation and applaud for having this kind of a program, and this is a decennial celebration, so it is really very nice to know that for the past 10 years they have been doing this program. And the torch, I think, which was lit by Professor Sunandan Sood is now being carried forward by Dr. Suresh. And I wish all of you to have a very successful training program, and I also hope that all the PGs will have very fruitful learning. And now I can see Professor Sunandan Sood. Welcome, sir. So thank you very much, and once again I welcome all the PGs who have come from far and wide, and again, once again, I congratulate the department for having organized this kind of a function. Thank you. Our beloved Dr. Sunandan Sood sir, ex-HOD, GMCH, and still a very much part of our ophthalmology family. Respected and worthy Director Principal, Dr. Jaswinder Kaur. Secretary for the event to kindly give the vote of thanks.
Good morning, everyone. It is with great humility that I take this opportunity to present the vote of thanks. I'm grateful to our worthy Director Principal, Professor Jaswinder Kaur, for her guidance and blessings for this event. Thank you, ma'am, for gracing the occasion. I extend a very hearty vote of thanks to the guest faculty from PGI for sharing with us their experience and pearls of wisdom. Many thanks to Professor Sunandan Sood for gracing this occasion, and to all invited senior faculty and colleagues from GMCH for sparing their time and gracing this event. I am thankful to the Medical Superintendent, Dr. Sudhir Garg, JDA Sir, Mr. Jasbir Singh, DMS, Dr. Sonali and Dr. Aditi for providing the necessary infrastructure for organizing this meet. Without the help of the engineering department, horticulture, sanitation, security, the CME would not have been possible, and express my gratitude to all of them. I appreciate the response shown by the trade, especially AMO, Novartis India, Zydus, Allergan and Carl Zeiss for supporting us wholeheartedly. For organizing any event, the wheels start rolling much earlier, and it requires planning, and I've been fortunate enough to be backed by a team of very experienced faculty colleagues, Professor Suresh, Professor Arya, Professor Subina Narang, and our new colleagues, Dr. Tanu and Dr. Alisha. Words fall short to appreciate the mammoth efforts made by our senior optometrists, Mr. Anil Kalia and Mr. Vinod Kumar. Thanks to all the senior residents, junior residents, optometry faculty and optometry students, the nursing and the ministerial staff, I cannot thank everyone enough for their involvement and their willingness to take on the completion of these tasks and going out of their comfort zones. Finally, last but not the least, I'm sincerely thankful to all the resident delegates for attending this conference in a big way, and I hope you learn something before the event finishes. We would be open to all your suggestions for the future events. I apologize if I have inadvertently missed out any name. Thank you so very much for making this event a success. And now I would like to invite all of you to join us for a cup of tea. Thank you so much once again.
Continuation with our academic session, now I invite Dr. Parul for top 5 pearls for biometry.
Today I'll be discussing top 5 pearls for biometry. So we've already discussed the biometry in the morning sessions. I'll just be highlighting the top 5 pearls. So despite technology, cataract surgery results still fall outside the normal range of desirable outcomes. So this was the biometry journey from ultrasound to optical, that is partial coherence interferometry, to optical, that is swept source OCT, which is the latest. So partial coherence or interferometry is in IOL Master 500 and swept source OCT is in the latest IOL Master 700. So pearl number 1, quality of scans is very important. So for A scans, when the echoes are high and steeply rising, the ultrasound beam is most likely on axis. The scleral echo should easily be identified. So this is the scleral echo. It should be easily identified, and the orbital fat echoes, these are the orbital fat echoes, should descend quickly and at a steep angle. If there are no scleral or orbital fat echoes visible, the ultrasound beam is most likely aligned with the optic nerve rather than the macula. So the beam should always be aligned with the macula to calculate the refractive axial length and not the anatomical axial length. So for IOL Master 500 and Lenstar, the reflections on the screen should be crisp. You see these 6 reflections in the IOL master, and 32 points, that is 32 reflections in the lens star in 2 circles. And the signal to noise ratio, which is a measure of the accuracy and decreases with increasing cataract density, should be more than 2. Also, a proper waveform should be there. That is a thin, well-centered primary maxima and a set of 4 small secondary maxima. 4 readings should be within 0.02 millimeters. For IOL Master 700, which is a swept source-based OCT, the foveal pit should be seen in the center. So this confirms the alignment. In this case, the foveal pit is not seen. So there is a poor fixation in this patient. Poor fixation. So this IOL Master 700 is able to judge that the eye is optimally aligned or not. Also, we are able to detect unusual eye symmetry geometries like the tilted lens, as in this case, which is not possible in IOL Master 500. And we can also visually verify our measurements. Pearl number 2 is switch to non-contact method. That is either the immersion method or the optical method. So as we know that the applanation A scan has a maximum error of 0.24, immersion A scan has an error of 0.12, and IOL Master has the least error margin. So we should always try to switch to non-contact method. In the immersion method, as we had already discussed, the probe is immersed in a small water bath in front of the cornea and the measurements are taken. It avoids problems of the contact A scan, that is no corneal compression is there and it is highly accurate. We all should know that a 1 millimeter error in measuring the axial length of a normal eye may produce around a 3 diopter error in the patient's final refraction. So we should be very careful. So in ultrasound versus optical biometry, so ultrasound measures the axial length till the internal limiting membrane, whereas the IOL Master measures the axial length till the retinal pigment epithelium. So it measures the axial length more accurately, and that is incorporated in the A constants. So you will see that the A constant in the IOL Master will be different from the A constant on the box of the IOL. That difference is due to the difference in the measurement of the thickness of the retina, that is between the ILM and the RP, that is around 200 microns. So optical biometry is preferred in cases of posterior cephaloma. So we ask the patient to look directly at the red fixation light, and the axial length measurement will be typically to the center of the macula then. So the refractive axial length will be measured instead of the anatomical axial length. And also optical biometry is preferred in silicone oil filled eyes, that there is a silicone oil mode in the IOL Master, both the 500 as well as the 700, so we can use that to calculate the IOL pass. Pearl number 3 is always verify. Take a second reading when in doubt. So you can use a second device, or you can measure the patient with the same device twice. Ideally measure the patient on 2 different occasions. If the patient is able to come only for a 1 visit, then get 1 measurement, have the patient sit down, blink, and then get another measurement. The cases that should be verified are the borderline measurements, or when we are unable to measure, 2 eyes measuring, having a more than 0.3 mm difference in axial length, and eye is 25 millimeters or longer. Optical biometry most often measures long eyes too long, causing hyperopic surprises. So we can perform immersion and B-scan biometry to verify if we are not using the latest generation formulas like Barrett Universal 2 or Olsen. Somebody who doesn't have that, we can repeat with the immersion or the B-scan biometry. We should repeat a keratometry if corneal curvature is more than 47 or less than 40 diopters, and the difference between the corneal cylinders is more than 1 diopter between the 2 eyes. Average value of K is taken as 43.5 diopter or 7.76 mm. Pearl number 4 is a formula factor. So use multiple formulas and then compare the results. Variability between the formulas results can point towards unusual biometries like shallow anterior chamber or thick or thin lens. So Barrett's Universal 2 and Hill RBF, which is a artificial intelligence based formula, and now even the Keynes formulas, they work for all ranges of axial lengths. So this is the Barrett's Universal 2 formula. This has this is available online, as well as it is incorporated in the IOL Master 500 and the 700. This is the Barrett's toric for calculating toric IOLs. This is the Hill RBF formula. This is also available online. And the Keynes formula available at iolformula.org. And And in cases of prior refractive surgery, we can use the Barrett-Trouquet or the Trouquet-Toric if it is a toric lens, and Hegi-Zell for post-LASIK vision correction eyes. This is the Barrett-Trouquet Toric calculator, and we also have the ASCRS online calculator, which has settings for prior myopic LASIK, prior hyperopic LASIK, and prior RK. The latest is the Optiwave refractive analysis, that is the ORA. It is a real-time intraoperative abrometer, and in this the measurements are taken after the cataract has been taken out, that is in the aphakic mode. So it calculates the sphere, cylinder, and the axis. So we can directly calculate the power intraoperatively and then put the IOL. So ORA, it is useful in two scenarios. Number one is it improves the astigmatic outcomes. So it is useful in toric cases to see if any rotation is required or not. And we can even correct our refractive surprises after a toric IOL implantation with the ORA. So if there is a residual cylinder, we can rotate, or if there is a rotation of the cylinder of the toric IOL post-surgery, we can rotate it using the ORA. It is also useful in prior myopic refractive surgery patients. Point number 5 is importance of the ocular surface. So dry eye can lead to irregular astigmatism and increased abrasions. So easy way to identify it is topographically axial curvature maps will show multiple small flat and steep islands. So in this case you will see that the keratometry is showing a difference. There is a difference between K1 and K2. There is a significant astigmatism present. But 1 month later, after steroids and lubricants and cyclosporine for a month, the keratometry almost normalized. So we should always check dry eye before planning, especially toric IOLs. 1 diopter of keratometry error can lead to 1 diopter of around 0.9 to 1 diopter of IOL error. And we should always remove the contact lenses well in advance before doing biometry. So hard contact lenses around 4 to 8 weeks prior we should remove, and soft around 1 to 2 weeks. Artificial tears and warm compresses can also be given for MGDs, which might also disrupt the tear film and then hence the ocular surface. And for premium IOLs, we might advise LipiFlow. Other pearls include IOL constant optimization by the online services of Dr. Hegis and Dr. Hill. So IOL constant should be optimized for a particular surgeon. Like in Hegis, you have 3 A constants, A0, A1 and A2. So A0 is a surgeon specific A constant that needs to be optimized. A1 and A4 are already optimized and set at 0.4 and 0.1. So if you optimize Hegis, it is a very good formula. Number 2 is strict tolerance IOL. We should use relatively good brands so that we are sure that the IOL power that is written on the box is the power that we are actually implanting and it is not some other power. So we will not get surprises. Then the third is a second eye prediction refinement by applying 50% correction factor. So if we are implanting a 23 diopter lens and we get a -2 hyperopic surprise. So the next eye, if we have to plan, then we will do a 50% reduction. That means instead of 23 diopter, we will implant 22 diopter. So that 2 will be divided by 1, that is 50% correction factor will be applied. Thank you so much.
Thank you so much, ma'am, for this wonderful talk and briefing us all with the recent advances that's happening. Now I would like to invite Dr. Jitendra for his talk on top 5 pearls for the management of soft cataract.
Good afternoon, everyone. So I will be speaking on phaco in soft cataract and will try to give you people some tips to how to operate such patients. So basically soft cataracts are seen in pediatric or any other young patient, and we may see soft cataract in diabetic patient who present early, and steroid and some other drug-induced cataracts can also be softer in consistency. So basically nowadays increasing patient awareness and evolving lifestyle requirements also bring patient earlier to the doctor. So how does phaco in a soft cataract differs from a routine or a hard cataract? So we will try to touch those things. Because in routine cataract surgery, when we have good consistency of the nucleus, we can do different nuclear maneuvers like phaco choke, stop and choke, and divide and conquer. But in soft cataracts, we are unable to perform these maneuvers because consistency of the nucleus is not harder. So when we try to impale our phaco tip, it will directly harm the porcine capsule. It will not have hold on the nucleus. So consistency wise, we will be needing different kind of maneuvers to tackle soft cataracts. So I will show this video that when we go unprepared in a soft cataract, when we don't consider its uniqueness from a routine case, these things can happen. So a continuous curvilinear capsule axis was made. You don't have sound? Okay. So after doing hydrodextration, hydrodilation maneuvers, so here I have not taken any kind of precautions regarding a soft cataract. I have directly going in a routine way, and I am trying to make a trench in the cataract part. So you will note that I have mistakenly did deep trenching, thinking it is a routine hard consistency cataract, and I just avoided being in touch with the posterior capsule. See the hole in the center. So if we don't take care of softer consistency of the nucleus, we may have such kind of problems. But ultimately this was managed and IOL was implanted successfully. So this was just to show that how soft cataract behave differently. So now coming to the pulse, like what can be done differently. So whenever we examine patient in the pre-op, we have to anticipate whether this patient will be having a softer lens or a harder consistency lens. So log series is standard classification. Whenever its grades are 1 to 2, it is more likely that the cataract will be of softer consistency. So always check pupillary mydriasis also, because a soft cataract in a small pupil will be a perfect recipe for complications. So whenever you have a good preoperative awareness regarding the softer consistency, you can prepare well. Now coming to the next part, like when you have started phaco, what about the size of capsular axis? You need to make a good large 5 to 5.5 millimeter capsular axis, so that if you want to prolapse the nucleus into the anterior chamber, you can do it easily. If you make a smaller axis, then it will be difficult to prolapse the nucleus into the anterior chamber. Hydro procedures are very important, particularly in soft cataracts. So if you do a good amount of hydrodissection followed by hydrodilation, you can easily do the different maneuvers with the central softer part of the cataract. You can bring the cataract into the anterior chamber, you can just flip the cataract inside the capsular bag, or you can just tilt the cataract. Regarding the machine parameters, if you do phaco, you need to do phaco on lower parameters in softer cataracts. Your flow rate, your phaco energy and your vacuum should be on the lower side of the machine parameters. Usually a vacuum of 200 to 250 is sufficient for softer cataracts, and aspiration flow rate and water height should be low also. So for nucleus handling, we have two type of maneuvers. Either we can handle the nucleus inside the bags, so these are called endocapsular techniques, or we can just take out the nucleus from the bag and do phaco in the anterior chamber. These are called supracapsular techniques. So coming to the supracapsular techniques, what we can do, we can just do a good hydrodilation and bring the nucleus into the anterior chamber. But when we are doing phaco in the anterior chamber, we need to put dispersive OVD to protect the endothelium, so that our endothelium is protected from the phaco power. So I will demonstrate this supracapsular hydroprolapse in this video. So after staining the capsule with red and blue dye, this was a patient of who was operated earlier for retinal detachment surgery and has a silicone hole inside the eye. So it's better to stain the capsule to make the visibility better. So after doing routine steps, now you need to make a good capsule axis of size 5 to 5.5 millimeter. as I said earlier, a good size capsule axis will help you to prolapse out the nucleus into the just above the capsule. So now the hydro procedures, hydrodissection was done. Now being the hydrodeletion was done. Now see, the nucleus has come above the capsule axis margin. Now we can easily take care of this prolapsed nucleus in the low energy phacoparometers. This is a special kind of chopper I use for soft cataracts. It has a blunt tip. If you note that the tip is blunt and it is curved from the end. So this tip will not harm the capsule if you go near to it also. So usually the phaco can be finished within few minutes if you follow this kind of technique. So the nucleus is practically out. Now the epinucleus part is being taken in the epinucleus setting of the phaco machine. So after removal of epinucleus, routine steps of cortex removal and polishing of the capsule should be done. What you are looking at, like you are still seeing some of STs in the capsule. They are silicone oil globules which are present behind the posterior capsule, so they will stay there. So this is another video of showing the supracapsular hydroprolapse. So basically, after performing a good size capsule axis, what we need to do? We need to do a good hydro delineation from the, like, we need to put water around the nucleus but inside to the epinucleus. Epinucleus and nucleus should be separated. So again the nucleus is come out of the capsular bed. So again the phacoemulsification can be done in the anterior chamber very easily. Coming to the other technique, endocapsular techniques. In these techniques, as the name says, we will try to emulsify the lens inside the bag only. So we can do this thing by two techniques, phaco flip method or chip and flip method. So basically what is phaco flip method? As the name says, we will hydro delineate the nucleus and we will flip the nucleus upside down. And chip and flip method, what will we do? We will take central hard, relatively hard part with the phaco probe, then the remaining epinucleus plate and peripheral nucleus will be flipped. So I will show this chip and flip method in the next video. So here if you note that after doing hydrodissection, this is hydrodelineation ring which you can see. Now I will take this central part of the nucleus with the phaco probe and I will clear this area. So see, when I am trying to break this with chopper, it is not easily breakable because it is soft. Whenever I try to push chopper it and try to break it, it gives away. The cheese wiring happens. That's why the soft cataracts, they differ from hard cataracts in consistency. So now I have taken out the central part. So now the epinucleus and peripheral nucleus part is still there. I will try to flip this residual bowl. I'm trying, sometimes I'm getting failed, but now finally I have flipped this and see, now this is totally flipped and now it can be done in few seconds. So another method is tilt and tumble method. In this technique, what we say, like we do hydrodissection, Then we will try to just tilt the nucleus inside the bag. We will not flip it. We will just do hydrogenation and we will keep putting water on one particular side, so that from that side the nucleus goes up and other side goes down. So there is a tilt in the nucleus. So in this way we can finish phacoemulsification in soft cataract. So after finishing capsulorhexis, see the lateral side of this nucleus is above the this thing, left side of the nucleus. So there is a tilt. Now I am trying to make this tilt more prominent, and I will just go near to the edge of this tilted nucleus, and I will finish the phacoemulsification in the capsule only. So what is the benefit of doing phaco in the capsule? Like the energy dissipated and which can harm the endothelium is less in endocapsular techniques. So it is always better to finish phaco in the capsular bag, not in the anterior chamber. But here in the soft cataracts, even if you do phaco in the anterior chamber, no much energy will be dissipated, because these nucleus have very less consistency, so very less phaco energy will be needed. But if you you coat the endothelium nicely, no harm will happen to the patient. So again, single piece has been implanted in the bag. So sometimes if your cataract is not so soft, it has little hardness, so you can go ahead with your routine stop and chop technique also. Like after making a capsulorhexis, so what I have done here, I have taken the superficial soft cortex part with the pre-phaco setting. Now I am trying to make a trench. With this blunt chopper, this technique is easy, because you can go to the periphery and just cross the equator and go below the nucleus, and this chopper will not harm your capsule. So routine choppers, they have sharp edge. This chopper has a blunt edge and curved. Like here, you can just go beneath the behind the nucleus and just finish the phacoemulsification into multiple parts. So in not so soft cataracts, this stop and chop technique still works. So again, after removing cortical matter and doing polishing. See, in young patient, polishing is of utmost importance, because if you don't polish the capsule, the residual lens epithelial cells can lead to the formation of PCO, and in young patient the tendency of developing PCO is very high as compared to older ones. So when you must have seen most posterior polar cataracts also, they also have a softer consistency in nucleus. So posterior polar cataracts differ in the technique of operating them. Like you need not to do hydrodissection in posterior polar cataracts. You can just do a limited hydrodelineation, and you should you should avoid hydrodissection, because in posterior polar cataracts your lenticular opacity is just tucking on the posterior capsule, and if you do hydrodissection, it can just blow out the nucleus and blow out the lens, and the nucleus may drop in the vitreous cavity. So here what will we do? We will do just hydrodelineation, and after doing hydrodelineation, I will just take central part of this nucleus. So again, stop and chop method was used, and central part was just calcified. Now the epinucleus is remaining, and I have again Now you can do hydrodissection at this step because you have taken most of the central nucleus part. The softer things can be easily hydrodissected and taken out with the epinuclear setting. So now you will see a pseudo hole kind of picture because when I remove this cortex, there will appear a hole-like thing in the posterior capsule, but that is a pseudo hole, that is not a true hole. Now see, it looks like a hole in the center, but it's the hole in the cortex. The capsule is still intact. So after doing cortical removal and polishing, you can just implant. Go ahead with the fingerpiece. So take home points from my talk is like, be careful in preoperative examination to anticipate the softness of the nucleus. A good capsular exercise is required in soft cataracts, and use of right instruments such as blunt tip curved chopper and low parameters on the phaco machines is of very important. And choose right nucleotomy techniques as per the situation. Every technique doesn't fit into every case, so you have to customize your technique according to the situation. And thorough polishing of the capsule is very important in young patient to prevent further pressure formation. Thank you.
Thank you so much, Dr. Jitendra, for sharing these beautiful tips to manage the soft cataracts. Any questions from the audience? Now I would like to invite Dr. Vipul Agrawal for his talk on advancing eye care with high performance OCT.
Hi, good afternoon to all of you. I am Vipul Agrawal. So today we are here to discuss about the advancing eye care with a high performance OCT. So OCT is basically stand for the optical coherence tomography, and with the help of OCT we can take a cut section imaging of a retina. It will help you in a case of retinal diseases, glaucoma diseases and the anterior segment analysis. So we will go through one by one. So firstly we will see about the introduction of our OCT, like what are the basic technology on the previous time and what are the new one technologies are available, on which optical principle they are working, and what is the benefit of these new optical principle as compared to the previous one. So as you know all that OCT was starting from 1980s and still it is going on a research studies like what we can do new thing into the OCTs. So in the initial time OCT was a time domain OCT. In the time domain OCT the resolution of a tomogram was not so much better, and also it will take a little bit more time to capture on a patient. So in a 2007 we introduced a new OCT that is based on the spectral principles. So on the spectral one the resolution increases and the speed of acquiring a scan was decreases. After that there is a new technology that is known as the swap source OCT. In the swap source OCT, the speed is much more as compared to the spectral one, and the resolution and the depth of the image was much better. With the help of a swap source, you are taken a better choroid as compared to the spectral and the time domain one. So in the 2019, we introduced a new OCT that was the Sirius 6000. Basically, it was the spectral domain OCT, but it have a speed of 1 lakh A scan per second, and because of that the depth was the 2.9 mm. So we will also see in that detail particular after some slide. So OCT basically is a non-contact high resolution for the in vivo viewing of axial cross-sectional and three-dimensional imaging of anterior and the posterior ocular surfaces. So this is a OCT image of a normal patient. Here you can see the foveas, and this is the optic disc areas, and this is the choroidal place, and these are the retinal layers. So we can differentiate the layers according to the basis of hyper and the hyporeflectivities. So if we like differentiate the OCT, we have a three kind of a OCT. The first one is the basic one where you can see like the screening of a patient of a particular disease. The second one is the research tool, where are some of modification for the research, for your research study, and also a new technology that was the OCTA, the OCT angiography. It is a non-invasive technology. You doesn't need to inject a dye into the patient to see the vascular nature of a patient onto the retinas. So that OCT angio was start from the Cetus 5000 and into the Cetus 6000. You will see there is a lot of research tool there. You can manually like select the segmentation where you have to take a vascularization of a particular patient, and also the speed and the resolution was much more. So as you see in the 6000, the resolution was the speed was the 1 lakh A scan per second, with the previous one the 68,000, and because of that only the depth was the 2.9 mm, and because of that depth 2.9 mm you are able to see the choroidal vasculatures. So OCT will help you in a case of maculas with the macular cube, HD raster scans, and the OCT angiography. In a case of glaucomas, we have an optic disc cube and the OCT OCTA angiography in a case of the ONH. So in the ONH we have a different parameter like the perfusion density and the flux index that will help you to see the progression of a glaucoma. And another one is the anterior segment. You can see the cornea and the corneal thickness, the pachymetry, and the epithelial thickness. So in the OCT we have a three screen, like the patient screen where you have to enter the patient data, then the acquire screen where you have to take a nice scan, then the analysis screen where the tomogram image will come and you will analyze all your data. So one of the important technique in a OCT is the fast track. If the tracking is there, you see there is a difference, like this is the image without a fast track, and you see there is not a continuous blood vessel, there is a break of the blood vessel in between of them. And in a case of with fast track, you see this is the continuous vessel. So in a case of OCT angiography, there is a sum of motion artifacts. So to reduce the motion artifact, we need to a tracking analysis, and that will in the OCT will help with the help of the fast track. So what the OCT 6000 will do is, it will take a scan at a 270-100 faster and a 43% faster in a case of OCT angiography, because OCT angiography is a process that is depend on the patient response. If the patient is continuously moving their eye, then the instrument taken a more time to capture the OCT angio. So that is it is need a patient cooperation, and the test should be very speedy so that there is no such kind of a motion artifact should be there. And also it will take a little bit of time, like a 0.4 second in a case of OCT cube scan. That was very speedy. If the patient is very incooperative or the patient have some kind of a tear film dry eye disorders, then in that particular case the speed is taken a scan very fastly and you doesn't need to compensate for your responses. So this is a typical OCT angiography 12 into 12. So you see this is a non-invasive technology. In that particular, there is no need to install a dye into the patient veins, and you see the vasculature very beautiful. So these hypodense area is the a non-perfusion areas, and this hyperreflectivity, these are the new vessels generations. So in a case of the retinal diagnosis, you see there is a different protocols. So one of the protocol is the macular cube 512 into 128. On that we will take a macular thickness, macular change analysis, ganglion cell analysis, advanced RP analysis. If it is a case of your Druson's and PD, you are better to see in a case of the advanced RP, whether it is attached with the choroid or it is uplifted. Then there is a panomap, then there is a 3D visualization. If there is a case of retinal detachment, it is better be seen with the help of the 3D visualization. Then the advanced visualization. In the advanced visualization, you will see a cut section of a retinal layers. So this is how the macular cube report will look like. So this is the EDTRS cube. Here this central one is the 1, then 3, and this is a 5 mm of your circle. And according to that, the thickness basis, you will consider the patient for the early detection of diabetic retinopathy. If the patient is coming to you for the diabetic retinopathy screening, you have to take a nice scan, the macular cube. The second most advanced feature of that macular cube is like this particular cube is the 6 mm of length and the breadth. So if you want to see a particular disease at particular point, so what you have to do is like you have to scroll these icons to that particular areas, and you are able to see a small to small pathology at particular place. If there is a case of drusen, so if there is a small drusen like 4.5 or a 3 micromm drusen, you can able to detect with the help of the macular cube. So these are the after the macular cube there is another scans, that was the HD scans. HD scans is basically high definition, so you will see a better resolution of an image. So this one is the HD1 line, then HD21 line. HD21 line, when you have to like cover the more areas as compared to one line. Then HD radial, it will help you in a case of the foveal disease. If it is a case of the macular hole and the laminar hole, the HD radial will show you a better results. Then HD cross. HD cross will cover your both horizontal and the vertical scans, so you will see the depth of any hypo and the hyperreflectivity surfaces. Then the most advanced feature is the macular change analysis. If you are follow-up of a patient, you have to look at the patient, what is the change of your medicines. So the macular change analysis will help you. So in the macular change analysis, what is the important point is you have to take a scan from the first position. When the patient is coming to you, take a scan from a particular point, the A point from the retina. When it is come to you for the next time, it is also the OCT have to take a scan from that particular point for the comparison. If you taken the scan from another position, how you can compare your results. So this will help you in a case of macular change analysis. So as you see in that particular reports, this is the first visit of a patient and this is the second visit of patient, and you see this is the difference over there, like how the thickness of a patient was increases or decreases. On that particular basis, you have to start a treatment of patient. Then after the OCT, there is a different retina workplace station. The one of that is the forum, and in the forum there is a workplace like the forum retina workplace where you can compare the fundus and the OCT reports and for the like better visualization. So in that particular report, you will see like this is the fundus report and this is the OCT report. And if you scroll these lines over the forum, you will see at a different positions. So you can compare the fundus and the OCT report. And here also some of the statistical analysis, as you see here the macular thickness, this is the macular thickness statistical analysis, the number of visit of a patient. So in the initial time the thickness was more, but when you give a treatment to the patient it was decreases onto the follow-up of the patient, and suddenly it was increases. So as you know, well, because the follow-up of the patient, you know what the history of a patient, and according to that you will go through to the treatment. This is all about the retina one. Then the second one is the glaucoma one. In the glaucoma one, we have a ONH 200 into a 200 protocol. So in that particular basis, you will click a ONH tomogram, and according to the normative database, the OCT will tell you whether it is the structural, what is the structural losses coming and what is the not. So this is the RNFL thickness onto the quadrant wise, the superior, inferior, and to the temporal, and this is the RNFL according to the clock hour wise. And this is the different parameters that OCT was captured, like the RNFL thickness of the right and the left eye and the symmetry between the right and the left. If there is a dissimilarity between the right and the left eye into the RNFL, then there may be a patient of the glaucomatous. And this is the deviation curve. As you see here, this like reddish and the yellowish line. So it will show you that in that particular area there is a problem to the patient in a case of RNFL. So these color codings basically stand from the normative data. If it is a red color, that means there is a like only the 1% of population have this kind of a thickness. That means it is into the problematic case. If it is a yellowish color, then it is to the 5%. That means it is on a borderline. If it is a green, that means it is on a 95%. That means it is near to your normal case. If it is a white, then it is on to the 99%. If it is a gray, then it is it is not documented in that particular data is not with the OCT. In the glaucoma also there is a progression analysis as you have taken a HFA, the perimetry report, they have also a progression. So in the HFA you are taken a progression how the functional losses of a patient is going on. When you are coming to the OCT, they have a structural losses, like how the structural losses were going through. So for the GPA, you need to take a 5 visit of a patient. Initially 2 was counted as a baseline, and on that basis the OCT will show you the progression. So this is how it will show you the progression, like this is the initial 2 on the baseline, and these the follow-up of the test of patient, And these are the visit of a patient. As you see, the average RNFL thickness, it was decreasing, like the rate of change was 0.19. The superior RNFL thickness, the rate of change was like minus 0.19. But when you are looking toward the inferior RNFL losses, there is a sudden loss. The rate of progression was much more, that was the 7.36. So that will show you like how the vision loss of a particular patient is going on the structural basis. Then in a case of early detection of glucomatous, you have to take a ganglion cell analysis. So in the ganglion cell, the same as compared to the RNFL, it will show you the deviation curve from the normal population of the right and left eye. And these are the thickness map, and these are the thickness. So the red color will donate you there is a loss of ganglion cell, and on that basis you will thinking that there is a sum of functional losses of a field of a patient. So this is the progression of ganglion cell, same as compared to the RNFL. Then this is the combined report of structural and a function. Like you will combine the two reports, one from the HFA and one from the OCT. The functional one is coming from the HFA, like these two upper reports was coming from the HFA, and the lower one it is coming from the OCT. And here you will see overlapping of structure and a function. The below color coding, that is red and this green is from the OCT, and that black dotted over there, it is coming from the HFA. So as you see, you will compare that the red area is coming over the like your black margin. So you will compare how the structural and the functional losses is going on to the patient. And the third part of OCT is the anterior segment. So in the anterior segment, we have two attachment. One is for the cornea and second one for the anterior chamber. So in the anterior chamber, you have to take a scan for your angles also. So this is the virtual gonioscopy. You can compare the result with the gonioscopy, but you cannot replace the gonioscopy with the help of the OCT. So it will give you the parameter like AOD 500 angle open distance at a 500 micro mm, angle open distance at a 750 micro mm. The teaser trabecular iris areas at a 500 and at a 750 mm, and the scleral spur angle. So on that basis, you can classify the patient about whether it is a close angle and an open angle glucomas. Then another case is the anterior chamber, whether you can measure about the ACD, the anterior chamber depth, lens fault. If it is a case of a ICL, you can also measure the lens fault with the help of anterior chamber. Then angle to the angle distance, or we can say white to white, the inner white to white or outer white to white you have to taken. Then the central corneal thickness, that you have taken with the help of like anterior segment OCT. Then this is another image of cornea. The OCT will give you a 9 mm of your corneal diameter. So this is the HD image of a cornea. Here you differentiate between the different layer like the sphere film, epithelium, luminous membrane, stroma, and the endothelium. If there is some kind of opacity onto the cornea, or there is any syndrome over the and the disease over the cornea, you can easily pick up onto the OCT. The second one is the pachymetry map. So the OCT will give you the 0 to the 9 or a 12 mm of corneal thickness at a different quadrant or different places. So you can take like this is the average of that central one, and this is the average of that particular quadrant one. So if when you are live on a OCT, if you click somewhere over the if you have to take CCT at that particular point, the OCT will show you that at that particular point this is the corneal thickness of patient. Then this is the another pachymetry map. It will help you in a case of the keratoconus because in the epithelial thickness. So if you are looking for the epithelial thickness thinning, so you can easily take in with the help of the OCT. It will also give you a 0 to 9 mm of circular map. You can compare with your pachymetries. Then the other thing is about the angioplex. So this is about the angioplex. Angioplex is basically non-invasive technology, and it will give you the vasculature of a particular eye. You can use in a case of the diabetic retinopathy, DRVO, CRVO, all of the disease you can cover with the help of the OCT angiography. The only limitation of OCT angiography is the field of view is little bit less as compared to your conventional fundus camera. Now the second thing is about it is not able to detect the leakage because there is nothing a dye over there, so that is why OCT angiography is not able to pick the leakage. Otherwise, when you are looking for the quantitative data like vessel density, perfusion density, FAZ, you all will calculate with the help of your OCT angiography. So this is the case of color depth retinal map. So this is the color coding. So we differentiate the color coding on three types. Basically, we divide the retina into the different segmentation: the superficial, deep, avascular zone, the choriocapillary, choroid, sub-RP. So as you have ever see over there, if there is some blood vessels show you the reddish color, that means it is on a superficial blood vessel, superficial segment of your retina. And if it will show you the green color, that means it is on a deep capillary basis. And if it is on a avascular zone of your retina, it will show you a bluish color. So as you see in this visit, these are the different segmentation, and this yellow spot will show you the FAZ values. So I just zoom so that you can able to see. These are the this is the vessel density. As you see here, the data is there. The central 1 mm of circle central to the fovea was the vessel density of this. This is the outer circle, that was the 3 mm. Then this is the another outer circle of a 6 mm, and this is the full. So you can compare the visits of a patient, and you can compare the vessel density of a patient in a angiographical change analysis. Like the first visit, this is the vessel density. In the second visit, this is the vessel density, and what is the difference between them. And this is the FAZ, like area, parameter, and the circularity are coming. So in the case of early detection of diabetic retinopathy, you can use the FAZ parameters, because the FAZ is enlarged in the case of early detections. So this is the report of change analysis. Like this is the first visit of a patient. So this is the first visit of a patient. The vessel density of a particular quadrants, and the in between of them. This is the second visit of a patient. This is the second visit, and you see in below that there is a delta mark. That means that shows the difference between the first visit and the second visit of a patient. So according to that basis, you will take a sum of treatments. Another like protocol is the ONH angio. So ONH angio have a benefit, like when you give a dye to the patient in a case of fluorescein angiography or a ICAG, it is not taken you the scan of radial pericapillaries area. So in a case of OCT angio, you are able to see the radial pericapillary areas like this, and on that particular area, what are the perfusion density at different quadrant and a flux index. So if I'm show you this place, so have a like this is the P will donate your perfusion density, and F will show you the flux index. When the patient is going to the more glucomatous, advanced stage of a glucomatous, the perfusion was decreases and also the flux was decreases. That will show you the like how the progression of particular patient is going on in different quadrants. So for the glaucoma, we have a three different parameters, like the ganglion cell analysis, RNFL analysis, and a perfusion and a flux index. So as you see, this is the patient. So we will compare the first visit and the second visit of a patient. Like at the particular first one, we have like 41.1. And here it will show you the distance, the difference between the first and the second. That was 0.9%. That means there is less perfusion, the less blood is coming to that particular area. That means the glaucoma was increasing. Then if you are looking into the angio, there are different protocol. Firstly, they started with a small small area. So the small one was the 3x3 that cover only the foveal position. Then we go through the little bit larger, that was the angio 6x6, then the angio 8x8, and then now with the help of montage, we are able to capture a 40-degree of field of view of your pars plana. So all the disc and your fovea will come into the single pictures. So this is all about the OCT new advancement. So if you have any question, you can ask. Enphase in images will give you a different cut section of an fundus report. Like if you take an OCT, it will give you a C-section images of different segmentation. If you want to see a RP on a different like C-section images, so you can take with the help of Enphase images. So when you take an image on a macular cube, it will automatically take an Enphase images. So you will see over there. And also the Enphase images will help you to see hyporeflectivity surfaces. If there is some kind of hyporeflectivity surfaces over on the OCT, you are better to see in the case of Enphase.
Smart Emulsifying and aspirate. ब्लेंडर ना रोटेट करूँ मटेरियल में पावर नहीं देनी करूँ मटेरियल में जो तो कोई लोड नहीं करेगा ना पावर नहीं देनी हाँ रोटेट करूँ रूम दे पावर समझ में पड़ेगा 2 3
It should not be like this. ये दूसरी साइड है ये तो ऑलमोस्ट यहाँ पे जो यहाँ पे एक्चुअली एंट्री करवाना है यहाँ पे ये तो वैसे होगा देखिए ये तो सही रजिस्टर सासा बैठ जा रहा है ऐसे से आई थिंक मैम का ऐसे अगर कोई एंट्री नहीं करेगा ठीक है सर अब जब ये एस मेरा ये जो मीटिंग आपकी है उसका जो ये वाला साइड है वो मेरे वाली साइड होना चाहिए ये पहचान उसको फर्स्ट ईयर सेकंड ईयर इसको पता नहीं चलता कि इंटेलिजेंस कौन सा तो वो शुरू से ही सर्जन से यही सिखाते हैं आपका लेंस का
We have a very good speaker and a very good retina surgeon amongst us, Dr. Rajiv Gupta, who is heading the retina services at Sangam Netralaya Mohali, and he would be talking to us about the comparative analysis of anti-VEGFs, Protocol T, and the real-world evidence for aflibercept in diabetic macular edema. So I would invite Dr. Rajiv Gupta to please deliver the talk.
Good afternoon. Thank you, Dr. Suresh, Dr. Parul, and the residents. It's my proud privilege to visit my alma mater here and deliver a talk. As told to me, I have to speak on Protocol T, and also there is a wet lab which has been going on since morning. The second part of the wet lab is how to deliver, how to give anti-VEGF injections, which will be hands-on exercise after the presentation. So my second talk would be a little bit briefing you about how to give intravitreal injections, like actually in practice how we give intravitreal injections. So there are two talks right now. So coming to the first talk, which is comparative analysis of anti-VEGF agents. So basically I'll be telling you about Protocol T and the real world evidence regarding use of aflibercept, that is Eylea, in diabetic macular edema. Now, every one of us knows that there are three popular anti-VEGF injections: bevacizumab, Avastin, ranibizumab, Lucentis, and aflibercept, that is Eylea. And fourth one now, Pagenex, is also being used a little bit, but it has not got any FDA approval for diabetic macular edema as of now. So I'm keeping that out of preview of this presentation. So there is always so much confusion. Which agent to use, which is most effective, how many injections to give, when to stop. There is, especially in practice, once a patient has received 2-3 injections, some are responding, some are not responding, and you are always now confused. If you don't know the protocol, you are always confused what to tell the patient now. Should we give 4th injection? And I have to give 4th injection after how many months? When to give 5th injection? After how much delay? So there is always confusion regarding that. So if one is clear about the protocols, that what is being followed in the most of the centers which have been discussed in which are evidence-based evidence-based data available with you, you have to follow that, then there will not be any confusion. So let us go through these slides, and then let's hope that I am able to remove that kind of confusion. So this protocol T is a large DRCR net study which was carried out in multiple centers, and here it was on diabetic macular edema patients. The patients were divided into, the actual number of the patients was 660, and these patients were divided into 3 groups. I'll be using now trade name because otherwise it will take a lot of time. So these groups were divided into Avastin group, Lucentis group, and Eylea group. So in all 3 groups, the injections were started as monthly injections, and then data was analyzed at 1 year and then at 2 years. Beside this study, there were many other randomized controlled trials, individual studies, but this was one of the largest studies. So here the protocol was that you have to, in diabetic macular edema, you have to start with anti-VEGF injections monthly, and you have to carry on, and there were indications when to stop and when to extend. So patients were scheduled to receive either these injections every 4 weeks, and for comparison, sham group was also included. So if there is improvement or worsening was observed after the last injection. Suppose you have given 1 injection, and at the next visit there is either improvement. If there is improvement, naturally you will give next injection, right? Because you will give next injection. If there is deterioration, even after giving first injection, that means that diabetic macular edema has worsened. Even then you are going to give next injection. So you this line here, that if there was improvement or worsening, then next injection was given. Suppose there was no improvement or worsening after 2 consecutive injections, then what to do? Suppose you have given first injection to a diabetic macular edema patient and edema has resolved. Now suppose the patient has become absolutely normal after the first injection. Now patient has come for second injection, you have to give it. And then after, the patient has come for third injection, then again you have to give it. When he is coming for 4th injection, so after the last 2 injections, there is no further macular edema, patient is absolutely normal, then treatment has to be deferred. So that means even if a patient has improved after first injection, you have to give 2 further injections, so that improvement is maintained, and thereafter you have to stop. So this is the meaning that if a patient has received 2 consecutive intravitreal injections and the condition has become normal. Suppose a patient has 6/12 vision, macular edema, and after 3 injections he is 6/6 and there is no edema. So then you have to stop. Then you don't have to give further injection. And suppose after first 3 injections there is no change. Diabetic macular edema is persisting, there is no change. Then you will think there is no improvement, then that means we have to stop. No. you have to continue till 6 months. So if a patient is presenting to you within 6 months, and even after 3 injections there is no improvement, like here they have told after 2 consecutive injection there is no improvement, and diabetic macular edema is persisting, you have to continue with the injection in the first 6 months so that he receives at least 5 or 6 injections, right? But if a patient is coming after 6 months, the same patient is coming after 6 months, and after 6 months you have given 2 consecutive injections and there is no improvement, then you have to stop or think of alternative treatment. So in nutshell, in first 6 months, if a patient is coming to you for the first time, he is improving with 3 injections, then you have to stop. If he is not improving with 3 injections, you have to continue till 6 months. After the interval of 6 months, patient is not responding to your last 2 consecutive injections, you have to stop or think of alternative therapy like Ozurdex. Is that clear? Any confusion so far? So that is in nutshell about protocol T. Even if you remember this one slide, the concept would be clear. So what were the results of protocol T regarding these 3 injections? How do they behave in the case of diabetic macular edema? So in this study, now this is all theoretical study, so don't get bored please, because all next 10-15 slides are based on evidence and graphs. So if you look here, there are 3 graphs, green one, and this slide is showing mean change in visual acuity. So how much was the vision gain at the end of 1 year after giving these injections in 3 groups? So it is clear from here that this is Eylea group. The maximum improvement was seen in the Eylea group, and second was Lucentis, and third was Avastin, right? So going to next slide, what happens at the end of 2 years? Now this is 2-year data. Now here again Eylea is at the top, but Lucentis is touching Eylea now. So at the end of 2 years, final outcome was same in Eylea and Lucentis, but Avastin was lower down. So that means at the end of 1 year, Eylea was superior to both Lucentis and Avastin, but at the end of 2 years, Eylea and Lucentis were equally effective, and they were superior to Avastin in the management of diabetic macular edema. Is that clear? And this is how much. Now, what was the thickness change in what was happening to macular edema? Was it going down in the parallel fashion? So again here, you see this is the decrease in macular edema. So again, Eylea showed maximum reduction in macular edema compared to Lucentis and compared to Avastin. So here also macular thickness was decreasing in the same fashion. Now there is a sub-analysis. The patients who had vision 6/12 or better, and the patient who had presenting vision which was less than 6/12. Was there any difference between these 2 subsets of patients in these 3 groups? So let's look at that. So when the vision was less than 6/12, that is 6/18 or less, vision was less than 6/12, 6/18 or less, then Eylea was far superior than Lucentis and Avastin. So if the presenting vision is 6/18 or less, then Eylea is far superior than other 2 molecules. And this efficacy was maintained at 2 years. Same was the result at 1 year, and same was the result at 2 years. But if the vision was between 6/12 or better, all the 3 molecules were, all the 3 injections were similar in efficacy. So this was when vision was less than 6/12, and this was when vision was 6/12 or 6/9. Then all the 3 injections were comparable. The results were comparable. So then next question is, if coming to the first slide, if Eylea is superior to Lucentis at 1 year, but it is not superior to Lucentis at 2 years, so should we give Eylea, or we can give Lucentis only? So this slide will answer that. Now, if you see here, at the end of 2 years, both Lucentis and Eylea have similar outcome. But if you see the area under cover, throughout the 2 year, mean gain in visual acuity was superior in case of Eylea group compared to Lucentis group. That means all the patients in the Eylea group are seeing better throughout the period of two years. They are able to drive in a better way. They are able to study in a better way. Now the final outcome is same, but those 2 years were better in case of Eylea group compared to Lucentis. So that is the outcome from this slide. So here again we can see they have this is the area under cover that Eylea group had better performance throughout the period of 2 years. This I have told you. So same thing which I have discussed just now, that throughout the period of 2 years the vision improvement was better. So was CST macular edema reduction same in different groups? So I think we can skip that. Again, macular thickness reduction was similar in the Eylea group compared to other two groups. Now, about 15 years back, whenever a patient of diabetic macular edema was there, you would do either focal laser or grid laser. Injections were not there. The first injection, bevacizumab or Macugen, they came into vogue in 2006. After the discovery of anti-VEGF injection, the treatment has totally changed. Earlier with laser treatment, there was hardly any vision improvement. If you are treating patients with grid laser or local laser, vision will get stabilized, but improvement will not be there. The improvement has been seen only with anti-VEGF injection. So there is the role of anti-VEGF injection. So what is the role left for laser treatments? Laser treatment role is left for one, if there is diabetic macular edema which is non-center involving. It is away from fovea. So you can give focal treatment so that focal macular edema does not come on to center, because if it comes into the center, then anti-VEGF treatment has to be started. So if there is a focal diabetic macular edema, non-center involving diabetic macular edema, so then focal treatment has to be given. So nowadays, after the invention of OCT, macular edema is no longer used as focal and diffuse macular edema. It is always classified as diabetic macular edema, which is center involving or non-center involving. So if it is non-center involving macular edema, you have to give focal laser so that it does not become center involving. Or in case of center involving diabetic macular edema, you are giving anti-VEGF injections, and say after 3-4 injections the edema has resolved and only little bit component of non-center involving diabetic macular edema is left. That is outside 500 micron from the center. Little bit edema is left. Then you can add focal laser. So that is the only indication left for laser treatment these days. One for non-center involving diabetic macular edema, and second for diabetic macular center involving diabetic macular edema, which on follow-up are becoming non-center involving diabetic macular edema. So there is the now they have also studied in these three groups what was the proportion of patients requiring laser treatment. So again you can see here that the laser treatment over the period of 1 year and 2 years, the Eylea group required lesser laser treatments compared to Lucentis and Avastin. So only 41% in the Eylea group required laser treatment, 64% in Avastin and 52% in the Lucentis group. So this was the protocol. Whenever they engaged patients in multiple centers, different people carried out the injections, they clubbed the results, and this was the protocol that came out. But what about the real world evidence? What about the people who have, other than this trial, they have used the injection? What do they feel about this? So multiple studies have been done across the world, and like one of these studies 2018 by Campospolo, and he also found that aflibercept is working better than this was a small study, 29 eyes from 15 patients, and this was the again in diabetic macular patient. This was the first published study for the use of Eylea in DME. So they found out that vision improvement is there and macular edema reduction is there. So, but this was the first study. Then there is a Poland study. Here also they can see Eylea group is performing better than Lucentis and Avastin. And I'm talking about Eylea, but I am telling you I give maximum number of bevacizumab injection in my practice. I have used so much Avastin and I'm still using Avastin so much, and in comparison to Avastin I'm hardly using other anti-VEGFs. There are so many other issues also, socio-economic status of the patient, that is also very important. So everybody can't afford expensive injection. So mean change in visual acuity at 12 months. So here it is again interesting slide. Here they have compared that patients who were given 5 consecutive injections of Eylea versus patients who were not given 5 consecutive injections. They were outside protocol. So it was seen that those patients who received 5 consecutive injections in the beginning, they performed much better compared to those who were receiving injection here and there. So this is FRB registry trial comparing Eylea with Lucentis. They have shown better result with Eylea. And various retina societies, European Retina Society, again they have also seen that aflibercept is better in DME, especially if the vision is 6/18 or less. Cochrane meta-analysis. This is a huge analysis. Meta-analysis is, if you look at the studies, what is the evidence from a particular study? What is the weightage of a study evidence-wise? So meta-analysis has the number 1 weightage compared to randomized controlled trials, individual studies. So meta-analysis is where all the randomized controlled trials are put together and compare. So in this study also they have seen that Eylea group favors DME management over comparators. So just to document here, one of our patients with DME here received first Eylea here, 370 micron thickness, received second Eylea after 1 month, 374, received third Eylea injection here, thickness is coming down 350 micron, vision is improving to 612, presenting vision was 618, and this is at the end, at the last follow-up. The thickness, DME has almost gone 259 micron CMT, and vision has improved to 6/9. So this kind of result you can compare, you can have once you are treating your patients with anti-VEGF injection. So the key messages are, going by the trial, individual decisions you have to take in your clinical practice depending on socioeconomic status, other factors, but going by the trials, going by the evidence, if aflibercept is the drug of choice in the treatment of patients who have presenting vision which is less than 6/12. And in patients who have 6/12 to 6/9 vision, for them all 3 injections behave in a similar fashion. Why aflibercept is more effective? Because it traps VEGF as well as it blocks placental growth factors, which are also involved in the pathogenesis of DME, and its affinity to block VEGF is much more, 100 times compared to Lucentis or Avastin. In addition, it is able to counteract VEGF, which is not inhibited by Lucentis or bevacizumab. So this was all about protocol T and the real world evidence. So any questions regarding this before I go on to the injections technique?
Excuse me, sir. A little out of context, sir. What is your take on?
And for wet AMD it works very nicely. We have used in 2-3 patients recently, and all the patients, see, you are not using brolucizumab as a first line management as of now, because there is evidence that wet AMD, DME, See, only 2-3 incidences happened across the country where there was one spurious vial, including GMCH. One spurious vial came, all 20-30 patients were given injection, and all of them went and developed endophthalmitis, right?
Yes.
There were no endophthalmitis before that, and there were no endophthalmitis after that. The risk is of litigation only,
yes,
right? Now I'm using Avastin for the last 15 years. In our center, we have been using, we did not stop because off-label approve is there, off-label label is there, and off-label we are using vancomycin and ceftazidime for the treatment of endophthalmitis. That is also off-label use. Use of ringer lactate in cataract surgery is also off-label. So that off-label does not mean you cannot use it. Off-label means that in various studies, it has been seen that it is effective in the management of particular disease, but only thing is FDA approval is not there. But there is a lot many evidence from the clinical studies that it is very, very effective and one can use with as a off-label. You have to tell patient that it is off-label use and you can use it. Off-label does not mean that you cannot use it. So off-label means you have to tell, inform patient that it is FDA approval is not there, but in clinical studies there is ample evidence that it is very, very effective and it is going to help you, and then you can give it. So we are giving it. Now calculate the risk of endophthalmitis and the risk of litigation. So that is the only deterrent in, I think medical college should start it, because Avastin is far cheaper compared to Lucentis. Avastin vial cost about 27,000 and you can have 20 injections from one vial. So one dose will be around 1500. Lucentis cost is 20,000. So 1500 versus 20,000.
Big difference.
Big difference. And now you have seen from protocol T that in the management of DME both are similar. And in wet AMD all three are similar. Except for IPCV. In IPCV, Eylea is definitely only treatment available. There Lucentis and Avastin are not going to work because 67% polypregression is seen with Eylea. But with Avastin and Lucentis, only 20% polypregression is seen. For PCV, Eylea is the only drug of choice. But for wet AMD, all three are similar. Now you take 100 patients. You give Lucentis and you give Avastin. All 100 patients of Avastin are able to afford it. You have to now. It is very important that you should be knowing the protocol for management of wet AMD. It is monthly for 3 months. No issue, no doubt about it. Monthly for 3 months. And if everything is going on well, then you have to treat and extend. There is no role of PRN treatment now these days. If somebody thinks that PRN treatment is going to work, it is absolutely no. After that, it has to be treat and extend. That you have to gradually increase the interval. Then fourth injection will be at a gap of 2 months. No, 2 months after the third injection. Right? Fourth injection. Fifth injection will be after a gap of 3 months after the last injection. And last injection will be, fifth injection will be at a gap of, next injection will be at a gap of 4 months after the last injection. And thereafter, throughout life, 4 monthly injections have to be given. So that is treat and extend. So a patient will have at least 20-30 injections, maybe more, during his next 10 years. So now you compare Avastin with Lucentis group. Lucentis in a medical college will cost 1500 rupees to a patient. You say 2000, including maximum 2000. Throughout life, he is able to afford the treatment, and all 100 patients with wet AMD in Avastin group, if they are presenting vision is 6/9, they will be 6/9 only, 6/9 or 6/12 throughout their life. Clear? Now take the Lucentis group, 100 patient. I am comparing only 100. Patient will be in thousands. I am comparing only 100 patients in the Lucentis group. Only 4 or 5 will take treatment eventually, because one injection is costing 20,000. 5 injection will cost 1 lakh. After that, he will stop treatment. So only 5 patients who are taking treatment, their eye vision will be saved only for 1 or 2 years. After that, they will develop disciform scar. Their vision will drop to 6/60. They will fall into WHO blindness category. And rest of the 95% who are not taking any treatment, they will get blind in the 1 year also. So in Lucentis group, all 100% patient will become blind. But in the Avastin group, all 100 patient will be saved. Now compare the risk of litigation. Risk of endophthalmitis on only 1 in 3,000. if you give injection, that is lesser than phaco, 1 in 3000. For litigation, there should be a combination of 3 factors. Patient should lose eye because of endophthalmitis. Patient's attendant is not understanding. He does not understand the complexities of medical treatment. He wants to go for litigation, right? And third, if there is any complication and negligence. So in a Western group, only 1 patient will develop endophthalmitis out of 3000 patients. And nowadays, out of 10 endophthalmitis patients, 9 can be saved with intravitreal Renko and Septa. Only 1 patient will develop serious endophthalmitis which will require vitrectomy. Maybe 1 eye will be lost. But it is not necessary. So risk of endophthalmitis practically comes, eye losing from endophthalmitis will be 1 in 10,000. So just to save 1 patient, you are making 9,999 patients blind. Just to save 1 that endophthalmitis patient that you don't want to, and that much risk will be there with Lucentis also.
Endo can happen with
right?
that also.
That also, and that 1 patient out of 10,000 who is developing endophthalmitis in Avastin group, not necessarily he will go for litigation.
Yes.
1 in 1 lakh chance is there that the patient will go for litigation. So we don't have to be afraid of litigation because we have to save thousands and thousands of eyes.
Which is need
if litigation happens, let it happen. I'm going to face the challenge. Doesn't matter. If there is no negligence, it is only complication. We can fight it out in the court. So that is the answer.
Biosimilars versus the branded version of any of these drugs?
I have never used biosimilar in my life so far in 15 years of practice. I have used lot of Avastin, Lucentis and Eylea and recently few Paginex, 2-3 Paginex injections, but I have never used biosimilar because there were so many reports of intravitreal inflammation because I am using Avastin in most of my cases. So why to use biosimilar which will give inflammation and will be expensive than Avastin? No? Yes? Avastin has to be given. You can't do medical practice, medical retina without Avastin. Especially if you go out in your private practice, if you don't start Avastin, you can't run your practice, I'm telling you. And in medical college, it is affecting poor population, poor and rich, and nobody can afford.
Yes.
Eylea or
Even
Lucentis
rich
for
can't
throughout
afford
life.
for
Yes.
entire
Until
life.
unless they are insured. And in our country,
Nobody
there is
is
hardly any insurance for anti-VEGF injections.
Yes. We are planning to restart.
You have to start. So many times we are, you may not be knowing, we are Saturday friends also. Every Saturday evening we discuss and I hammer it into his mind that Avastin has to be started. And it's very nice that he is starting this.
We are planning to restart
this thing again. Yeah.
Thank you.
So this won't be that boring, video based. So I'll be just telling you very, very simple technique of giving intravitreal anti-VEGF injections, and we all read in textbooks, but how we practice that can vary from hospital to hospital, institute to institute. I'm showing you what we are doing in our center. So first of all, the most important is that you have to procure the drug vial from an authorized dealer so that we don't end up having a spurious vial and get endophthalmitis. So purchase it from authorized distributor, and in your hospital you have to store it at 2 to 8 degrees centigrade. So these are 3 injections I was talking about, right? These are the packings. The purchase cost for Avastin is 27,000, but you get 20 doses. For Lucentis it is about 20,000, it is a single use. Eylea, you won't believe, it is 46,000. So now come to the trials, how to use such an expensive medicine. So those who can afford and their vision is less than 612, those who can afford, there you can give Eylea as per protocol T in DME patient. But in Indian population, those who can't even afford Lucentis, there you have to, whether it is 612 or less or more than 612, you have to use Avastin only. right? And for wet AMD, there is no problem. In wet AMD, all three are similar, so you can use these things. And this is our OT setting. It has to be given in operation theatre in India. That is that has been told by VRSI, and that is also documented in AIOS guideline. In Western world, they are giving in injection rooms in OPD only. But in India, you can't give it in injection room. It has to be given in OT. So most important that eye should have been identified in the pre-recovery room only by the nursing personnel over there. That eye should be taped, which eye has to be injected. And when his patient is coming to you for injection, this is called timeout. That you ask OT staff to show you the file and you see the diagram which eye is affected. Otherwise, you may end up giving the injection into the wrong eye. That will be negligence. Endophthalmitis in the same eye is not the negligence, but injection into other eye by mistake is negligence. So you have to open the file. I always do that. Whenever patient is coming to me like this, I ask my OT staff to show me the file. I see the eye and the diagram, that left eye DME or left eye wet AMD. Only then I proceed further. And this is our trolley for Avastin. If you see, not much of paraphernalia. Just this is the 1cc syringe, 26 gauge needle, iPad, drape sheet, towel, 3 buds, Castroviso, and Caesar. That's it. And how to take out the medicine for Avastin. For Eylea and Lucent, it is simple. It is a single dose. Just take it out and use it. But in Eylea, there were so many options described that you have to prepare Eloquits, store in the refrigerator. That is very cumbersome. That can't be done. But it is good that they have allowed this kind of method, and we are doing this method. That every time, whenever we have to give injection, we clean this thing with spirit, the top of the vial with spirit, and with the 26 gauge, we are taking out the Avastin and we push it back till 0.1 mark is achieved, 0.1 mark. And then we replace the 26 gauge needle with 30 gauge needle. With 30 gauge needle, and then you push the plunger so that you are left with 0.05 ml. Right? The dose to be injected is 0.05 ml. Initially, you have to take 0.01 ml because half of the medicine will be left in the needle hub. So you have to take double the medicine, so that when you push, half the medicine will be in the needle hub, half has to be injected. Clear? And this is how to take Lucentis. This you do with the needle provided by Lucentis people. That is a micro pore filter needle. Needle is same for Eylea as well as Lucentis. Here you go vertically and aspirate the medicine. You have to clean the top of the vial with the spirit and take out the medicine. And next is local anesthetic drop. One drop should be instilled in the recovery only, 5 minutes before the procedure. And as soon as the patient comes to the OT, then you have to repeat one drop more. After putting the drop, then you have to clean it with povidone iodine. So this is how, after next day, then you put a drop of povidone iodine and then clean the skin area with iodine. Iodine drop should be betadine drop should be the last drop to be put in the eye before the injection. You should not put antibiotic after the, right, or anesthetic drop after the betadine, because those are not that sterile. Those eye drops are not that sterile. So local anesthetic drop has to be put first, and then you have to put a drop of betadine. After that, no drop should be put till you inject the medicine. Clear? So in OT, as soon one local anesthetic has been put in the recovery room, and as soon as the patient has reached you, you have to put one drop of Sensoricane, right, Sensoricane, and then you have to put one drop of betadine, and then you scrub the area, paint the area with betadine. So these are very essential steps. If you follow these steps, no endophthalmitis will happen. And then dry up the area after 3 minutes. Then you have to give contact interval of 3 minutes because betadine acts only in 3 minutes. It becomes antiseptic only after 3 minutes. There are people who just start surgery immediately after putting the betadine or cleaning with betadine. It is not going to help you. And then you have to, with the bud, you lift the eyelid and then you apply the drape sheet so that eyelashes are separated out. And last is injection part, which I will show you here. Here you can see the injection part is that with Castroviso you make a dimple at 4 mmR. You make a dimple 4 mm. With the bud you support the eyeball and go inside. The needle should be towards the mid-vitreous. The vibrations are because of laptop, not because of my hand. So then you just massage the needle side and this is over. So very simple, just make a dimple, support the eyeball with the bud, go in and take out. And post-op here is same that you apply pad and patch for 2 days, for 2 hours, and it's a day to look for endophthalmitis because risk of endophthalmitis is 1 in 3,000. So you don't have to call them after 5 days, you call them after 1 month so that hospital visits are decreased. So that is about anti-VEGF injection technique. Any questions? You use that technique that you go oblique and then go little bit. That is not required because it is a 30 gauge needle. Even with the 27 gauge vitrectomy, people are going straight. With Ozurdex, which is 23 gauge, we go oblique and then we go vertical. For anti-VEGF injections, and use always 30 gauge needle, never 26 or 27. And you have to go right straight towards the mid-vitreous cavity. Take it out and just massage it with the bud. That's it. Keep it simple. Most important which I have learnt is over the years. Earlier what I used to do to decrease pain, that we used to put 1 drop of local anesthetic in the operation theatre and then we would keep bud in the area to be injected for about 1 minute and then I would inject. But lately I read somewhere we put 1 drop of local anesthetic in the recovery just before patient is moving into operation theatre. That is about 5 minutes before the procedure. And we put 2nd drop of Sensoricane in the operation theatre. So these 2 drops 5 minutes apart will make the procedure absolutely painless. So 2 drops 5 minutes apart, that is the carry home message if you don't want to give pain to the patients. Right? And betadine of course should be the last drop and 3 minutes contact time if you don't want to have endophthalmitis. Yes please.
Is there any role of IOP lowering drugs in post-injection?
No, we never give IOP lowering drugs. Reason being, I have done so many RD surgeries and must have done more than 500 in last 15 years, buckling procedure, which these days are almost gone. So I always thought that pressure would become very high next day, right? Next day morning pressure was absolutely normal because on the table you give 240, you do SRF drainage and then you put a 240 band, sometimes you inject gas also. eyeball is so tight, but there is a capacity of eyeball to get into the equilibrium. The whatsoever extra fluid is there, that will dissipate into the choroidal circulation, and the pressure will normalize after 2-3 hours.
Most Ozyodex also, sir?
For Ozyodex also, we never give any IOP lowering medicines, tablet or something, just simple antibiotic. How many of you have given Lucentis or Eylea? Did you find any difference between Eylea and Lucentis injections, taking out the medicine? There is a difference. I find it so difficult to take out Lucentis. The company people, they mention the vial contains 0.23 ml, right? And when you take it out, it is roughly 0.17 ml. And if you are not able to take out fully, you can't even leave a tiny drop in the bottle. Otherwise, your dose will be, it is just 0.05 when you are injected. So you have to take the complete dose out. But for Eylea, it is 0.23. There is so much medicine which is left. 0.27 it is, in fact. So much medicine is left in the vial. And when I'm throwing it out, I feel so bad. I keep counting that I have thrown 10, it is 46,000, right? And you have to inject only 0.05 ml. So I keep counting. I have thrown 10,000 rupees worth of medicine onto the floor. Now it has become 20,000. And now it has become 30,000. We are using only 50,000 worth of medicine. So 30,000 you have to put on the floor. National wastage. So Lucentis, you have to be careful in pulling out the medicine. Any question? Please.
Have you had any experience of patients shifting from Lucentis to Berocca because of financial constraints?
So many.
And how was the outcome?
Similar. I have never seen any difference between bevacizumab and ranibizumab. Never. So I hardly use ranibizumab. Either it is Avastin or Eylea. Eylea to in PCV cases mostly. There are hardly any patient where I have to shift from Avastin to either Lucentis or Eylea primarily for failure reasons. For DME, I shift to Ozyodex, stay away from Avastin. Only for ECHS people we are giving Lucentis because it is the only molecule which is approved by ECHS. So all ECHS patients we are giving Lucentis. But all paid patients are getting Avastin. Knowing that there is Eylea for You program throughout the country now. So for 2 injections they give 3 free vials. The aflibercept people, if they are sitting here, for 2 vials they provide you 3 free vials. So that patient has to purchase only 2 vials for 46,000 and 3 he will get free. So per injection cost is same as in Lucentis.
Almost 20,000
in the government sector. So it is same as Lucentis. So and protocol T tells you that Eylea is far better than other two. So here if you are treating a patient with Lucentis or Eylea in DME patients, you have to choose Eylea for less than 612. For 612 and above you can use Avastin. Anything Avastin or Lucentis whatsoever patient would prefer.
For wonderful presentation. I think it's an eye-opener presentation. Whenever I take Viva or ask residents, they always say Lucentis, Lucentis, Lucentis. And I always counter them, no, it's Avastin, Avastin, Avastin. So now things have been clarified. I think for future reference you have, very clear idea which way to go, which anti-VEGF to be given. Thank you. So anybody who is left with FICO, shall I still going on or they are through? Okay, DCR wet lab is going to start. So all of you who have opted for DCR should go with Dr. Alicia. You will be taking and Dr. Ujjwal. Thank you very much. So tomorrow we will be starting at 9:30. So tomorrow is at 9. So all of you are requested to be on time because we are going to start at 9. Okay, thank you.